this off. All right, can everybody hear me?
Yes.
All right. Good morning, everybody. So I'm gonna we're gonna go over the last two, actually, lectures 7 and 8, and then next week on Wednesday we're gonna go over lecture 9. So I'm gonna share my screen with you all, and then we'll get started. Oh, if anybody has any questions before, just hop on in and just let me know.
All right. I have a quick one, Justin.
Yeah, what's up?
So I just kind of like made a little list regarding the coracoid process and coronoid process attachments. So for coracoid, I got pec minor, coracobrachialis, and short head of the biceps.
Yep.
Coronoid, I don't know how many of these we need to know. Pronator teres, brachialis, flexor digitorum profundus, and flexor digitorum superficialis. Does that sound right to you?
So for the coronoid, the one I would just specifically remember would be brachialis and then pronator teres. Did you find that coronoid process for flexor digitorum profundus and superficialis outside the lecture, or was it like explicitly said on the lecture, or did he say that?
You know, it's all a blur right now, man, but I want to say I found it on Complete Anatomy for those two.
Yeah, because sometimes they have like extra attachments, but I would just focus on like the ones that he highlights, because I remember clearly he said that the coronoid was going to be pronator teres for sure. That's like definitely the highest yield one.
Yeah.
And then brachialis for sure. I would say the lower yield ones would be the ones you just stated for flexor digitorums.
Okay, but as far as coracoid, definitely know those three.
Facts, yes, know those three for sure.
Awesome. Thanks, buddy.
Gotcha.
I also have a quick question regarding teres major. What's the innervation and arterial supply for that?
Yeah, so the innervation of teres major is going to be lower subscapular nerve, and then it's important to note that because subscapularis is upper and lower subscapular nerve, but teres major is only lower subscapular nerve. And in innervation, you don't need to worry arterial supply. You don't need to worry too much about the arterial supply for the teres major, just because it has a lot of arterial supplies, but because it gets a lot of branches, for example, like from the posterior circumflex humeral. It also gets some branches from the subscapular, suprascapular. So not too important to note the arterial supply for the teres major, but if you wanted to note one, it would probably be posterior circumflex humeral artery.
Thank you.
Yep. Do we have access to practice exams or any type of practice resource for the exam next Thursday? Yeah, so I'm actually working on the practice exam right now. So I'm gonna try and finish that this weekend and try to post it on either. I'm aiming for Monday, so I'm aiming to do it by Monday. Just because I'm still trying to do I just finished the notes for these two lectures, and then we have a lecture on Tuesday I have to work on, and then but I'm definitely gonna try and get it out as fast as possible. And the practice exam is gonna have 50 questions, so I'll write like a 50 question document, and then I'm gonna post it on my Canvas page under the modules, and then I'll post like one that's gonna be like the exam, and then like another one that's gonna be like the exam key, so like the answers for it. So then you can like take the exam and then like check the answers after. So I'll be working on that this weekend to make sure I can get that out for y'all. But yeah, I'll definitely be working on that practice exam for you. All right.
Hey, Justin, I have a question.
Yeah.
So he had mentioned, or like he included the Anconius muscle in both the arm lecture and the forearm lecture. But it's kind of like he goes more into depth on it in the forearm lecture. Mm-hmm. So for the vascularization of the Anconius, should we just think that it's like the posterior interosseous, or?
So for Anconius, I would just know it's most likely going to be radial artery. Again, like a lot of these forearm muscles do get arterial supplies from like branches of each other, but since the Anconius is mostly on the posterior side and closer to like the radial side, it'll most likely be radial artery.
Okay, thanks.
Yeah. Okay.
Oh wait, sorry, I have one more question.
Oh yeah, you can.
Then for the vascularization of the hand, so he didn't really say in the lecture for the thenar and the hypothenar muscles, but like from looking on like Complete Anatomy and stuff, those are the like palmar branch and the deep palmar branch, like for each side. So should we know like specifically that it's those two, or should we know that like the thenar is going to be radial and the hypothenar is going to be ulnar arteries?
Yeah, so I would say just like what you said, it should be like and 1/2 loaf. So for like thenar eminence, that's going to be median nerve, and then for ulnar or for hypothenar eminence, that's going to be the pinky. That would be ulnar nerve. So I think that's going to be the highest yield. But in regards to the arterial supply, yes, I think it's safe to assume that like anything that's going to be closer to the thumb will be any branch that's coming off the radial artery.
Okay, thanks.
Yep. Yeah, so there's a lot of, so Complete Anatomy, like it's amazing and it's good, but don't use it to like, I need to learn every single attachment based on what Complete Anatomy says, because that's just going to be like overwhelming and too much, and it won't be on the exam. What's going to be on the exam is what he posts on his lectures, as well as what he says in class. So those are like the highest yields of stuff. So like honestly, like I've never used a book for anatomy, and I did pretty well. So like everything that's going to be testable is either on the lectures or he says it, because Muffley likes to say a lot of things in class that aren't on his lecture. That is definitely testable material. So as long as you go to lecture and you take notes and like you understand what's going on in the slides, you shouldn't be worried about something being in the book or something being from Complete Anatomy, because all the information should be right there.
Actually, I have almost like a roundabout statement on that, because that I took that advice too. Like you said that early, and I've been kind of just going off of that. But this last lecture he did, I know we're not going over this today, but for the thigh, man, he left out so many innervations and so many arteries. But then he also puts in his slides the compartmentalization with the arteries and the nerves. But when he gets to the slide that's dedicated to that muscle, he'll just like leave out the innervation and the arteries. So where do we go from there?
Yeah, I know, because I know Muffley sometimes on some of them he has like the innervation and arterial supply, and in others he would just forget both of them and not put it on the slide. So if he doesn't put it on the slide, like, and he doesn't talk about it, like I wouldn't go out of my way to go like find it out. He didn't put it on there for a reason, most likely because it gets branches from like so many different types of arteries, so he didn't want to list like 5 of them, and that's why he would just not list it.
Okay.
What? Yeah,
He misspells some stuff too, like
what?
the iliopsoas muscle or whatever. He spelled it wrong on a certain slide, and I was thinking it was an entire different muscle.
No,
I'm
yeah,
not confused.
yeah, no, Dr. Muffley doesn't like. I mean, with the slides, sometimes it's like some things aren't like spelled right, so like sometimes you got to work with it. I'll try and fix them if I point them out for you all. All right.
Can I ask a general question before we start? Sorry.
Yeah, you can.
It's just about your really helpful videos and in the one PowerPoint. So for some reason, when I try to watch them, my PowerPoint, like it lags. And I was just wondering if anybody else had that issues with the videos, and if there's like something I can do to like make them not lag, because they are really helpful.
Okay. I mean, if they lag, like what I can do is I can make like another PowerPoint with just the videos and then post it. So hopefully that would be like less like memory. So then it would probably be like less lag if you wanted me to do that. Or I could just send it to you with just the videos.
Okay, thank you so much. I can email you about it.
Yeah, just
later.
email me. Yeah, email me and I'll send you the PowerPoint.
Is it possible to post them on like each video separately on Canvas? Just because like I think that's a common problem with us, is like it's either lagging or like crashing our computers.
Yeah.
I was just trying to think of like alternate like
Okay.
options.
I can try and see. I could probably post it as like I could post 2 documents, so I can do like one for just the forearm muscles and then one for just the anterior and then one for just the extensors. So like I'll just do half on one, half another. So it would just only be like 3 videos and then 2 videos on the other one or something like that. So it shouldn't take up too much memory. Yeah, I think that's what I'm gonna do. I'll probably post the anterior flexors on like one PowerPoint, which would be probably like what, 3 slides or something like that, and then the extensors, which would be like another 2 or 3 slides on another PowerPoint. Yeah, I know. So yeah, it takes up so much memory. I'm telling you, it took me like 2 hours to upload that lecture, like in the morning. So I get you guys. Okay, let me share my screen and then we'll get started. If there's not any more questions. All right, let's see. Let me hide this. All right, everybody can see my screen, right?
Yep.
All right. So for this lecture, we're going to talk about the gluteal region in the posterior thigh, and then we'll get more towards the closer towards the leg when we get into the next lecture. So we'll take it from there. Okay. So, I mean, this is just the general stuff that he talked about with the lecture, like the pelvic girdle. I mean, we'll talk about the gluteal muscles, lumbosacral plexus, dorsal rami, branches of internal iliac arteries. So we'll touch upon all of these throughout the lecture. And then feel free to stop me as usual, because sometimes I talk fast sometimes. So if you want me to slow down or like clear anything up, I mean, just let me know, message in the chat, interrupt me, I don't mind. All right, so I mean, these are just going to be anatomical landmarks that he just talked about in the beginning of the lecture. So I would note them just because like we're going to talk about them throughout this lecture, next lecture, and the lecture after that, because there's so many muscles that attach to a bunch of these things. For example, the ischiospine is extremely important because that's going to be the attachment point for lots of muscles, as well as the ischiotuberosity. So like they said, this part is going to be the yellow part's going to be the ilium, the blue part would be the ischium, and then this red part's going to be the pubic ramus, or the pubis, right? So we'll talk about all these throughout the lecture, and we'll I'll reiterate which ones are going to be super important in regards to the muscle attachments. Same thing over here. The limbus is just like this little lip thing that's surrounding the where the femur goes in, right? So the femur is going to go into this like acetabular notch right here, and this little limbus thing, or this little lip right here, is just called the limbus, right? And then this is the lunate surface. So we'll touch upon these as we move on. Okay, so he mentioned in lecture about the arcuate line and how it separates the false pelvis into the false pelvis and true pelvis. So the false pelvis is actually going to be the superior portion, and the true pelvis is actually going to be the inferior portion. So I have on the next slide, I'll like clear that up to make it like perfect sense. So what this means. But other than that, he talked about the greater sciatic notch and the lesser sciatic notch. Super important because lots of nerves and arteries and muscles we'll talk about which go through the greater sciatic notch or lesser sciatic notch. When he says greater sciatic notch and greater sciatic foramen, they're basically analogous. They're like synonymous to each other. So when they use notch, it's usually just when they're talking about bones, right? So for example, like you just have this like random bone, it's usually just called greater sciatic notch. But in a living human, they call it like the greater sciatic foramen. It's just different terms, but they mean the same exact thing. And this is the obturator foramen because the obturator nerve goes through here. And we also have the obturator internus muscle and externus on here. We'll talk about this in the upcoming lecture. So these are just like overviews. So this is what he's talking about with the arcuate line. He said it in class. I wasn't sure if it was important, but I just put like a little slide just in case we can, just to cover it just really, really briefly. The arcuate line is just a part of this pelvic brim, which is this little red thing right here. So circling around the pelvis. And anything that's superior to that is going to be the false pelvis. And then anything inferior to this, which would be this blue area, is going to be the true pelvis. So just know that the arcuate line separates the false pelvis, which would be superior, and true pelvis, which would be inferior. I just wanted to touch upon that because he did bring it up in lecture. And then, so we have the greater sciatic foramen, like we talked about, and the lesser sciatic foramen. Remember, those are like used interchangeably, right? So with greater sciatic notch and lesser sciatic notch. Super important, I mean, eventually to know is that this is going to be the sacrospinous ligament. So if you think about it, sacrospinous, it's literally going to connect from the sacrum to the ischiospine, right? So sacrospinous ligament. So you can see it coming from the sacrum, going straight to the ischiospine. So this is the ischiospine right there. This ligament on the back, on the posterior side, is the sacrotuberous ligament. So it connects the sacrum to the ischial tuberosity, right? So they name them like from where they're attached, so it helps us a lot, right? So from the sacrum to the ischial tuberosity, which is easy to see here, from the sacrum to the ischial tuberosity. Okay, so this I would definitely put as like a huge star here. This is high yield, knowing what goes to the greater sciatic foramen and what goes to the lesser sciatic foramen. So remember, this is going to be the greater sciatic foramen, and this is going to be the lesser sciatic foramen. So the important things that go through the greater sciatic foramen are going to be, which we'll talk about, the piriformis. We'll talk about a bunch of muscles, actually a bunch of nerves that go through there. The pudendal nerve is actually going to go through the greater sciatic foramen and back out the lesser sciatic foramen. So the pudendal nerve is actually really interesting. I actually put a picture on it in like these next coming lectures or these next coming slides, as when like the pudendal nerve kind of just goes in through the greater sciatic foramen and it kind of just comes back out through the lesser sciatic foramen. So it kind of makes like a 180 degrees turn. So it kind of goes like this and comes back into the genital area, right? So it just goes like out here and comes back in. So that's why it's like it goes out through the greater sciatic foramen and then it goes back in through the lesser sciatic foramen. So these are going to be important to know, as well as the obturator internus, which is actually going to be one of the muscles. Its tendon is actually going to go right through the lesser sciatic foramen, which is located right here. So we'll talk about those. Okay, so just a quick comprehension check on what I just stated. So which structure passes through the lesser sciatic foramen, or also known as the lesser sciatic notch? So we have the piriformis, the pudendal nerve, the tendon of the obturator internus muscle, B and C, or all of the above. All right, so it is going to be, yes, B and C. So I'd like to make the questions in the PowerPoint like study helpful as well. So for example, like now we know like the pudendal nerve and the tendon of the obturator internus are going to be important muscles that go to the sciatic foramen. So you guys do the lesser sciatic foramen. So y'all can use it during your PowerPoints or during when you get the notes in order to study the lesser sciatic foramen. The piriformis is actually going to go through the greater sciatic foramen. Is the perineal region the same as the genital area? Yeah, it's kind of like the same as I would say. Yeah, it's basically almost the same thing. Yeah, that would be the perineal area. This is the summary. So I put this picture just to show you. This is actually, I took a screenshot from Complete Anatomy in order to help you picture this. So this is like your sacrotuberous ligament right here, going from your sacrum to your ischial tuberosity. And this would be this ligament right here would be your sacrospinous ligament. So it's going from your sacrum to your ischial spine. So this would be your greater sciatic foramen, right? And this little thing right here would be like your lesser sciatic foramen. So I put like a little summary in order for you to help you remember. What's going through the greater sciatic foramen would be piriformis and pudendal nerve. So I highlighted the pudendal nerve in purple. So you can see it's coming out the greater sciatic foramen, but it's coming back in the lesser sciatic foramen. So it kind of makes like this huge turn to go back and supply the genital area or the perineal area, right? So that's like an image that's going to help you like with understanding what the pudendal nerve does. We also have the sciatic nerve, which also goes through the greater sciatic foramen. We have piriformis and pudendal nerve. So for the lesser sciatic foramen, we'll have, you see this little obturator internus right here? This little muscle right here is the obturator internus. That's going to be going through the lesser sciatic foramen, as you can see right here, right? And then we also have the pudendal nerve, which we talked about. So this little slide is just to help you understand where everything is. We'll talk about these rotator muscles as we go on throughout the lecture. Okay, so I mean, he just talked about a couple regions of the femur. We have the greater trochanter and the lesser trochanter. Those are going to be super important attachments to muscles as we go throughout the lecture. We also have, I fixed this because he put medial epicondyle. This is actually the lateral epicondyle. You have medial, lateral, and medial again. We'll talk more about this probably when we get into the leg. The leg, remember, is going to be from the knee to the foot. The thigh is going to be from the hip to the knee. So from the hip to the knee is the thigh, and then from the knee to the foot is the leg. That's what they technically call it. It's the same thing with like how we call the shoulder to the elbow, the arm, and then the elbow to the wrist, the forearm. It's the same thing in the lower part of your body. And then
Justin, quick question that's kind of unrelated, but not really.
Mhm.
Back when he was talking about the when we were going over the superior or the rotator or the supinator muscle. Sorry.
No,
I noticed that on one slide he wrote the lateral condyle, and then on another he wrote lateral epicondyle, talking about the arm. And I assumed they were the same thing for the arm, and then I saw here that there's an epicondyle and a condyle. So I just wanted some clarification on that.
Yeah, I think it stated the lateral condyle, I believe, but I could be wrong.
And then
I think it was lateral condyle.
He has two slides. One of them says lateral condyle, and then the other one says LE. So I wasn't sure. I assume that meant lateral epicondyle, but I guess my question's more: is there like a condyle in the arm, or is it interchangeable in the arm?
Yeah, there's condyles on the arm as well. It's the same thing. They have like lateral and medial condyles and epicondyles as well in the arm. Yeah, but it's not interchangeable. Like the epicondyle versus condyle is not interchangeable. So for example, this is the condyle portion, and this would be the more lateral side would be like the epicondyle portion. But he's not gonna. I doubt he's gonna test you. Does it attach to the lateral condyle or lateral epicondyle? It's just nomenclature. Okay. But yeah.
Okay, so go with condyle for now.
Yeah.
Okay, thank you.
Yeah. Okay. So, but that's going to be extremely like low yield. He's not going to ask like does it attach to lateral epicondyle or lateral condyle, because most likely the muscles are going to probably attach to a little bit of both because they're so close to each other. Okay. Yeah, I would just know, because remember we talked about the lateral epicondyle, the humerus, and the medial epicondyle. A medial epicondyle and lateral epicondyle being attachments for flexors and extensors. That's why we talked so much about the epicondyle. So I would just note that. I wouldn't know.
Okay, got it. He's not going to do anything like super tricky.
No, not like that. No, he wouldn't do that.
When you say not like that, what do you mean by like?
What I mean is,
what kind of tricky is he gonna?
Like he's not gonna be like petty tricky. Like he's not gonna say what's the difference between lateral epicondyle and lateral condyle. Like he'll more so be tricky in regards to like, for example, like the which we'll talk about, the pectineus muscle is actually, it helps with abduction. We know, like an abduction of the thigh, but it's actually also going to be supplied by the femoral nerve. So it takes obturator nerve as well as femoral. So a tricky question would be like, okay, so which one of these muscles does not have femoral nerve innervation? And the pectineus muscle does, even though you know it's an adductor muscle, and most of the adductors have obturator nerve. Pectineus also has femoral nerve. So you see what I'm saying? It's like those types of tricky questions, things that actually like make more sense and like are more relevant. You know what I mean?
Okay, that makes sense. Thank you.
Okay, got you. Yeah, he's not gonna. Yeah, he won't check you on like structures like that. Okay, and then intertrochanteric crest. We'll talk about gluteal tuberosity, which is going to be important for the gluteus maximus, and then linea aspera. We'll talk about that a lot more. The only thing he said was just the intercondylar notch are going to be the attachment for cruciate ligaments, but we're for sure going to talk about this a lot more in the last lecture on Wednesday when we talk about the leg. Okay, so for vascularization, I would note that the external, so what happens is that you have the abdominal aorta, right? So, which is like located right here, your abdominal aorta. This is literally coming from your heart, right? So your heart like branches off this aorta, which is like more like the largest artery in the heart, and it comes all the way straight down your abdomen, right? So it's right here, and then your abdominal aorta is going to basically bifurcate. It's going to bifurcate into a right and left common iliac artery, right? So right and it's going to it's going to turn into the common iliac artery, which then bifurcates into the external or internal iliac, right? So it's important to note that the external iliac is going to just be turning into the femoral artery. So like, remember how we talked about like with the subclavian artery turning into like the axillary artery and then turning into the brachial artery, like the same structure, they just name them different things as like it goes along. It's the same thing with the external iliac. The external iliac is just going to turn into the femoral artery. Femoral artery will eventually turn into the popliteal artery, and then we'll just eventually like go on down into the leg when we talk about that. So it's kind of just like just naming something different as it goes down the body, right? So that's important to note that. So
does the internal iliac turn into the deep femoral?
So no, the internal iliac is actually going to have a lot of branches, and mostly the most branches that the internal iliac are going to give off is mostly going to be branches for the gluteal region. So for example, like the superior and inferior gluteal artery, the obturator artery, etc., like those types of things. But The external iliac is going to turn into the femoral artery. Femoral artery actually branches off the deep femoral artery. So we'll talk about that later on. Does that help?
Yes, thank you.
Okay, got you. So yes, so it's important to note that like the internal iliac is going to like supply the gluteal region, right? Because that's going to be, like I said, superior gluteal, inferior gluteal, which we'll talk about. The external iliac is more so going to go and turn into the femoral artery and just go down the leg, right? So this is why I put that right here. So here's the common iliac, right? And then you're branching off into the external iliac and the internal. So you can see like the internal iliac just kind of stays in your gluteal region. And it just branches off like into a bunch of things that are important for a lot of your gluteal muscles, right? Your external iliac, on the other hand, is going to turn into your femoral artery, which will eventually branch off your deep femoral artery, which we'll talk about in the throughout this lecture. But what's important to know, like I don't want you memorizing like all these things because obviously he didn't talk about a lot of them. But I just put a star for the ones that are just important because he did talk about those throughout the lecture. So for example, like the internal iliac artery is going to have superior and inferior gluteal artery, internal pudendal artery, and then obturator artery. While the external iliac is just coming along the ride just to pass through. Like the external iliac doesn't want any business with the gluteal region, basically. It just wants to just go straight down to the leg, right? So that's going to be most important for the external iliac artery. So yeah, don't go memorizing this like picture. Just the stars are just the most important part. Okay, we've seen this like so many times already. He's put this on like 3 or 4 PowerPoints. Just note that the all the plexuses in the body are going to be formed by the ventral primary rami. I think that's the most important thing we need to know there, as well as that there's no such thing as a thoracic plexus, right? We have a cervical, brachial, and a lumbosacral plexus, but we don't have a thoracic plexus. It's just intercostals. So that would just be the most important thing to note here. So he talks about the lumbosacral plexus, and he just kind of just divides the nerves up into like what kind of regions they innervate. They're all going to make a lot more sense when we talk about the individual muscles. Like I said, remember like the pudendal nerve is going to like do like the genital area as well as like the perineal area, and the genital femoral, literally genital, like, you know what I mean? So it like makes sense as to why these are perineal structures. Same thing with the gluteal region. It literally says like nerve to obturator internus. If you know the obturator internus is a gluteal muscle or like roughly in the gluteal region, that should just make sense, right? Same thing with these. He just like divided them up into their own categories just for you to like understand like what specifically does what in each lumbosacral plexus. What I would note though is that the pelvic splanchnics are going to do parasympathetic innervation. So we actually talk about a lot of splanchnics later on in the next exam block in regards to the rest of the body, and most of them actually do sympathetic, but the ones that are going to be in the pelvic splanchnics are going to be parasympathetic. So preganglionic parasympathetic, meaning that they're just going to do things that are going to be parasympathetic in nature. So for example, like using the restroom would be parasympathetic, right? And then you have, I would also note that the posterior femoral cutaneous, oh yeah, see, he spelled this wrong, yeah. Yeah, he meant to put like cutaneous. So posterior femoral cutaneous gives off the inferior cluneal nerve. So when we talk about the cluneal nerves, those are just going to be sensory nerves for like the gluteal region. So for mostly like the gluteus maximus and lower back region. But when we talk about when these come up in the upcoming lecture, the superior and middle cluneal nerves are actually just going to be branching off the dorsal primary rami. Does anybody remember like what the dorsal primary rami was? What was so important about that? Like, why did we need to know that?
True deep back muscles.
Yeah, so like the dorsal primary rami are for true deep back muscles, and they're also going to be important for branching off the superior and middle cluneal nerves. So I would just add that to like your reservoir in regards to like what the dorsal primary rami are important for. In regards to the inferior cluneal nerve, that comes off the posterior femoral cutaneous, which will show throughout this lecture. So here's this drawing that just like, I don't know. Yeah, the drawing just got me a little confused, but because it's just a lot of lines everywhere. So I just found pictures online and just basically made it like this, just to make it like a little bit simpler as to what are the branches of the lumbosacral plexus that we need to know, because there's obviously like way more than this. I covered these two because these are not important. These are the ones that you don't need to know, well, because he didn't talk about it. But in regards to like this picture, it's pretty easy to like follow along what's going on. So for example, like you have genital femoral, which is going to like the perineal area, right? It's going to have like some L1 and L2. You have lateral cutaneous, which would be having some L2 and L3. Lateral cutaneous, it's important to note that like these nerves are just named after what they exactly do, right? So the lateral cutaneous is literally going to go to the lateral side of the thigh and supply cutaneous innervation. right? So that's good. That helps us like understand like what these nerves are doing, right? Femoral, we'll talk about a lot, which is mostly going to be the anterior thigh. Obturator, that's just mostly going to be medial thigh. And then we have lumbosacral trunk, which is just going to turn into some part of the sciatic nerve, which is located right here. And then sciatic nerve is just going to get branches from L4 to S4. I don't know how high yield. I don't think it's super high yield to know exactly what the branches are coming off of. But I put them here just in case you wanted to note them, because the professors that taught the leg lecture and the thigh lecture last year wasn't Muffley, wasn't Dr. Muffley. We actually had different professors teaching these 3 lectures. So these lectures are a little bit slightly different. So I don't know how important it's going to be for Muffley to like understand these like L4, L5, S1. I wouldn't put it at the highest of your yields, honestly. If it's the last thing you want to study, I would study it, but I wouldn't put it at the highest of your yields, just because it's just like, there's like, I feel like just asking about, does it come off of L1, L2, or 3, or like L2 or L3 is just kind of like not relevant to ask, you know what I mean? So just knowing like the generalizations, like in regards to like what they do, I think the most important one would be sciatic, which would be from L4 to S4, or L4 to S3. But other than that, I would just like note this just to get you a general idea of what's going on. So here's the sacral plexus leading. Yeah, is there a question?
Yes. So the previous 2 slides ago with all the lists, we don't have to know that for all of them. Is that correct? Not this one, the one before where he listed everything by area. Do we have to memorize this list, or just the 2 in green?
So yeah, you don't have to like memorize this list, just because you're going to know exactly what this list is talking about when we go throughout the lecture. So for example, like you don't even have to memorize this list after going through the lecture to understand which one is which. So for example, superior gluteal, we know that's going to be for the gluteal region, and then piriformis, we know that's a muscle for the gluteal region. Like they're just names in and of themselves that can like just describe what the areas they go to. So you can memorize it, but like I would just say as you like study the material, you're just going to know it. Like you're just going to know exactly where these go, so you'll know exactly how to categorize them. Do you see what I'm saying?
Yes, thank you for the clarification.
Yeah. And then again, like I said, a different professor taught this lecture last year, so that's why like, and it wasn't important to note like these structures, like the L, like all the way down to like S4. But for Muffley, like I would just say, I mean, study it if you want to. I put it here just to help you out, to make it super easy to like study it. But I would just study this like maybe like right before the exam and be like, okay, this is coming off L2, L4, or whatever. This is coming off that. But I wouldn't like focus like all your time on like memorizing the like which ones are coming off which lumbar nerve, etc. Does that make sense?
Yes.
So we need to know the spinal nerve levels in respect to the brachial plexus. Oh yeah, everything about the brachial plexus is high yield. Like you need to know like I talked about, everything that is coming off which spinal nerves levels, everything that's for the brachial plexus is high yield. So I would memorize that to the T. Lumbosacral plexus, like that's like give or take, but I would still like just maybe look at this like right before the exam just to like give you a brief like refresher on like which ones are coming off of which, just so you know like which nerves are like how they are in relation to each other. Because remember he says anatomy is super important in regards to relation, right? Like you need to know like what is in relation to what. Like for example, like I know the femoral nerve and the obturator nerve are going to be like lateral and medial in respect to the psoas major, which would be like a muscle that's like coming down here. So for example, like that's how the lumbosacral plexus will help me, because like I know like where things are in relation to each other, right? So, but brachial plexus, I would know like everything on there. So here's going to be the sacral plexus. So when he points at this, like for example, if he points at this, that's sacral plexus. But when he points at this is sciatic nerve. So like I said, this is the sciatic nerve, right? This thing, this ginormous thing. But if he points at anything that's over here, it's like sacral plexus, right? It's sacral plexus. A bunch of nerves that are just coming out of the spinal cord. So that's why when they point at this is going to be your sacral plexus, right? And then you see over here, this is actually going to be a sciatic nerve getting branches from L4 to S3. That's the one I guess I would just know, but that sciatic nerve is getting from L4 to S3. But that's literally about it. So this would be sciatic nerve, and this would be sacral plexus. All right, so a comprehension check question. So the sciatic nerve comes out between which 2 muscles? So the piriformis and superior gemellus. I know this is a little reach, but this is going to help you with your studies. So superior gemellus and inferior gemellus and obturator internus, or inferior to the quadratus femoris. You'll understand why I put this question in there. And this is like usually, like typically, I'm not going to test you on like exceptions, like things that like, because obviously it can come out of different places, but like 90% of the time it's going to come out of between like these two muscles. And this one's a little tough question because we didn't talk too much about the gemelli and then as well as the gemelli, but I'll explain why I put this question in there. Okay, so this is going to be piriformis and superior gemellus. So the reason why I put this is because I want you guys to understand the order of like these muscles. So for example, it's fair game to say which one of these muscles here are going to be superior or inferior to each other because they're literally like arranged in like kind of like a column straight down. So for example, you have your piriformis, which is located right here. Then you have your superior gemellus, which is this little muscle. Then you have your obturator internus, which would be this muscle coming through this little muscle with the tendon. Then you have inferior gemellus and quadratus femoris. So I even organized the answer choices in order so that you can understand what's going on from superior to inferior so you can use it to study. So this is why I put like piriformis and superior gemellus, because you have piriformis and then superior gemellus. And then you're going to have superior gemellus and then inferior gemellus. Dang it, I messed up on that. Okay, but I'll fix that. So it's superior gemellus and obturator internus. And then you have obturator internus and inferior gemellus. I'm going to fix that, don't worry. And then you're going to have from inferior gemellus to quadratus femoris. So I'm going to fix that just a little bit so you guys can understand what's going from superior to inferior, because it gets a little bit confusing because there's like 4 or 5 different muscles right there in the posterior compartment. So I want you guys to understand like which muscles are on top of which. So that's going to help you a lot in regards to like which ones are going to be supplied with which nerve supply. So I put this in here just for you to like study as to in regards to which ones are superior and which ones are inferior. So again, just in case you need some clarification, this is piriformis. This is going to be superior gemellus. This little tendon right here is going to be obturator internus. This right here will be the inferior gemellus. And this right here would be the quadratus femoris. So we'll talk about that as we go throughout, but I wanted to throw that in there in the beginning before we started talking about all those lateral rotators. Okay, we talked about the pudendal nerve, right? It kind of does like this little like 180 degrees thing. It goes out the greater sciatic foramen, and then it comes back in through the lesser sciatic foramen, right? And we didn't talk too much about the obturator nerve, but the obturator nerve has its own foramen. It's actually called the obturator foramen, which is it's where the obturator nerve goes through, which would be located right here. This would be the obturator foramen. So I just noted that. I mean, it says obturator foramen in and of its name, but I just wanted you to make the connection that obturator nerve goes through the obturator foramen, right? So that would be located right here. Obturator foramen. Right here, excuse me, obturator foramen. Yeah, so it's going to be piriformis, superior gemellus, obturator internus, inferior gemellus, and quadratus femoris. Yes, it's super important to know that order, because if you memorize that order, you're gonna understand the nerve supply into each muscle really easily. Like when I go through it, so it's important to like understand which one is superior to inferior. Yes, that's correct. Okay.
And what does the P and the O stand for on that slide?
P and O.
Or the OI there.
Oh, OI. This is gonna be the obturator internus going to the lesser sciatic foramen.
Oh, that's the muscle.
Yes. Mm-hmm.
And then the P is the piriformis.
Yes, and the P is the piriformis.
Thank you.
And then him putting like SG and IG is just like the superior gluteal nerve and like the inferior gluteal nerve. And then obturator, this would be the obturator nerve going through the obturator foramen. Right. Okay. So again, like I said, anatomy is all about knowing things in relation. So for example, this is the psoas major muscle, right? This muscle, not little, this is a pretty big muscle. This muscle right here. The genitofemoral nerve, which we talked about, comes off the lumbosacral plexus, L1, L2. It's actually going to go straight over the psoas major, like almost 90%, 95% of the time. If you look in a cadaver, the genitofemoral nerve is coming right over the psoas major. So it's like superior. So that's important to know in relation to that muscle. And then we have the femoral nerve, which is going to be actually right here, super small. I mean, it's not small, but it's super small to see in the image. That would be lateral to the psoas major. And then you have obturated nerve, which would be medial to the psoas major, which makes sense, right? So if we know that the obturated nerve is going to supply the medial thigh, right? So the medial thigh, then we know it's most likely going to be on the medial side of the body, right? So it's medial to the psoas major. So I would note these in relation to like which ones are which is why I put like a little note right here, just in case he tries to test you on the differences in regards to which ones are going to be located where. And then we'll talk about these gluteal region branches as we go throughout the muscles.
I'm sorry, Justin, I have a quick question. So those are all in relation to the psoas major, but they're not directly innervating the psoas major.
Yeah, that's correct, actually. Yeah, the psoas major is actually going to be innervated by rami. So like rami from the lumbar rami, basically. So you don't need to know that, though. The psoas major is not going to be innervated by any of these nerves. Yeah, that's a really good point. Yeah, good clarification. Yeah, the genitofemoral does not innervate it. They kind of just like pass over it. They don't want to be bothered with it, type of thing.
Thank you.
Yeah, of course. Yeah, good question. Okay, so we have gluteal region. So you have the superior cluneal and the middle cluneal. Remember, like I said, the cluneals are like just going to be for sensory. So like sensory, I mean like touch, for example. The superior cluneal and the middle cluneal come from the dorsal primary rami. So like I like to note things that have differences, right? Because that's usually what's testable, right? Usually Muffley is going to test on things that are like differences, right? So for example, like inferior cluneal is coming off of the posterior femoral circumflex. Posterior femoral cutaneous, right? So that's important to note because that's going to be the only one that's not coming from the dorsal primary rami. So like when I used to study for anatomy, like I would like to point out like major differences because I felt like those are the highest yields. But in regard to this, I would note that the inferior cluneal nerve comes off the posterior femoral cutaneous. Posterior femoral cutaneous. Remember, it sounds like a really long word, like we said, to name something, but it literally says what it does. Posterior, so to the backside. Femoral, so it's most likely going to be the thigh. And it's going to be cutaneous, so it's going to be cutaneous innervation, right? So it helps us that if we just break down the word into its individual components, we can understand what it actually does. Oh, he also said that he's not going to... Yeah.
Sorry, real quick, man. I was still thinking about the last thing we spoke about with the psoas major innervation. I want to say I think it does get some innervation from the femoral nerve.
So the psoas major, most of its innervation is actually going to be from the rami. Yeah, it's mostly going to be from the lumbar rami. Femoral nerve is not going to be mostly. If you looked it up, it's because femoral nerve is going to innervate iliacus, and then obviously we know iliacus and psoas major are going to come together to make iliopsoas. But the psoas major in and of itself, like when it's from this high up, is mostly going to be from the rami because the psoas major is going to be attaching to the lumbar spine.
So if he uses the broad term iliopsoas, is he going to use that or is he going to separate them?
No, yeah. If he uses the broad term, then you don't just identify that with like femoral because iliacus is going to be innervated by femoral. So I wouldn't. He's not going to. Yeah. Again, he won't trick you in that sense. Like you know what I'm saying? Like something that would be like kind of like ambiguous. You know what I mean? Like he's not going to trick you in that sense. But iliacus, no, is going to be femoral.
Does he favor separating them or just calling them iliopsoas?
So in the lecture, when he talks about femoral nerve innervations, he specifically says iliacus, right? So he never says psoas major or iliopsoas in regards to being supplied from the femoral nerve. So I would just note them as separately. I mean, if he says it like as one, because eventually they come into one muscle down here, he's probably most likely going to ask about its action, right? Which would be like flexing the thigh, right? Because they're both going to come together to help flex the thigh. Right. So that's most likely what but I don't think he's going to ask about innervation in regards to that. And if he does ask innervation, he's not going to be like, is it femoral or is it the rami from the lumbar spine? You know what I mean? Like it's going to be obvious. It's going to be like, okay, I know what he's talking about. It has to be femoral because it's not any of the other ones. Does that make sense?
Yeah. So psoas major, just ventral primary rami.
Yeah. That's just you don't need to note that. That's just that's just going to innervate the psoas major muscle because it's not going to be innervated by femoral nerve.
All right. Thanks, bro.
Gotcha. Okay. Yeah, you guys are asking really good questions. Okay. Iliopsoas is part of the floor of the femoral. Yeah, it's part of the floor of the femoral triangle. Yeah, it is. Yes, it is, as well as the pectineus, which we'll talk about. Okay, so he talked about dermatomes, and he said that he's not going to test on them. Okay, that's good. But I would still note about the thing that I talked about, like about the forearm and the hand lecture. Remember I said like those, because those are from peripheral nerves. So he never specifically said about peripheral nerves. So I would still study those. I mean, because I know it's super high. It was super high yield for us last year. So I just don't want you guys missing out a question because he didn't specifically say it this year. So I would still study it. But in regards to dermatomes, he said you don't need to study that. So I wouldn't study dermatomes. But I just
when he
posted.
says peripheral nerves, does he mean like the superior cluneal? Like, what does he mean by that?
So he means for peripheral nerves, he means things that are like, for example, like, do you remember like in the hand and forearm lecture when we talked about sensory, for example, it was like a picture of all these colors, like you had axillary nerve, ulnar nerve,
yeah, so
like
it's
those
just
types
like
of nerves
the
are peripheral.
sensory.
Yes, the sensory innervation for like major nerves. Yeah.
Okay. So, and for this, the example he would give would be like the superior cluneal, the mid cluneal, or the inferior cluneal.
Mm-hmm.
That's what he'd test on.
He could test on this as well. Yeah. He could test on that
like
as well.
That's what a peripheral nerve would be.
Yeah. These would be small peripheral nerves. Yeah. Yep.
Okay. All right.
Anything that's not motor, right, Justin?
What?
Peripheral is just anything that's not motor, right?
So yes, yeah, yes and no. I think because peripheral nerves, like for example, like axillary nerve is a peripheral nerve, but it's obviously going to have some motor innervation to like the deltoid muscle, but it also has some sensory innervation as well. So I wouldn't just classify it as like just sensory. I would just note that they're just nerves away from the spine, basically.
Okay.
Does that help?
Yeah, definitely. Thanks.
Okay.
Thank you. Sorry.
No, yeah, you're good. I know these things like kind of get like confusing because they sound interchangeable, but when they're actually not. So for cutaneous innervations, yeah, I would note cutaneous innervations. Dermatomes, he said not to worry about. Okay, so this is just a summary. Again, I just put like a little summary slide to note the posterior femoral cutaneous, which comes off the sciatic nerve, is going to give off the inferior cluneal. Remember the middle and superior cluneal come off the dorsal primary rami. And right here, yeah, so dorsal primary rami. I added this because I wanted you to not forget this, supply the deep back muscles, and then give off superior middle cluneum. Okay, so we'll talk about all these in these upcoming muscles. I just put this like in a little slide right after this just to make it a little bit easier because I felt like a lot was going on here. So I simplified it just like this. So basically this is what he said on the last slide. But just note that like the femoral nerve is going to take the anterior thigh as well as the femoral artery, right? So it's going to take most of the anterior side of the thigh. The medial thigh is going to be obturator nerve and obturator artery, so that'll be the medial side of the thigh. And then posterior, in regards to artery, is going to take the perforating branches of deep femoral artery. That's almost like the same thing when we talk about the arm. Remember we talked about the posterior side of the arm is going to be deep brachial artery. It's the same thing with the leg. It's going to be deep femoral artery. So a lot of things relate to each other in regards to like where they supply. So it's going to be perforating branches of deep femoral artery for the posterior side and then sciatic nerve as well. So I'll be putting this a lot throughout the lectures. So just to remind you quickly about what's going on. Okay, so for tensor fasciolata, that's going to be attaching to the iliotibial band. It's coming from the ASIS, which is just the anterior superior iliac spine. You could actually feel that. Like for example, if you put your thumbs and you press hard, like in the front side on your your abdomen, and you like touch your hip bone, that's going to be your ASIS basically. That would be your anterior superior iliac spine. So you can kind of feel that if you actually palpate it. That would be the tensor fasciolata. And then the innervation, I put a huge star. This is like definitely important to note. Superior gluteal nerve. So like you said, like he didn't put the arterial supply for the tensor fasciolata, right? So I wouldn't like go out of my way to like go look for the tensor fasciolata arterial supply, right? If he doesn't like talk about it, I'm not going to go out of my way too much to look at it unless he like categorizes it in a certain compartment, right? So for example, like all medial is going to be obturator artery, for example, like, you know what I mean? So like things like that. But that's going to be important. So I put like a little picture here. So you'll see like throughout the lecture, I put like, he would put like his slide, and then I put like a really, really simple slide right after it just for you to like kind of like test yourself or like to help you understand where this muscle is. So for example, like this slide has everything what this slide has, but just like in one picture and like a little note. So I try to make it like super simple in order to like help like test yourself and like understand like what these muscles are doing. So for example, this is the tensor fasciolata, which is actually going to attach to the iliotibial band, which you talk about, and the ASIS, which is right here, your anterior superior iliac spine, right? And it's going to be innervated by the superior gluteal nerve, right? So that's important to note, superior gluteal nerve. I put like a little chart or a little slide in regards to which nerves are going to do which muscles, so that you guys can stay organized in regards to what's doing what. But yeah, this slide has everything that this slide has, just like in a super simple version. So with the gluteus max, yeah.
Sorry, I have a quick question. So for something like that, should we also know the function? Even though he doesn't specifically say it.
Yeah, no, I mean it's going to be an abductor, so it's going to help. If you know, like for example, if you know the origin and the attachment, you would know what the function does, right? So for example, if you pull this muscle, or like you contract it, right, it's going to pull the leg and thigh outwards, so it's going to abduct it, right? So the tensor fasciae latae is important in abduction. Does that make sense?
Yes, thanks.
Okay, yeah, that's why it's so important to know these like of origins and insertions, because if you ever like ask about actions of muscles, all you need to do is if you remember the origin and insertion, and you just pretend like you act like, okay, if I contract that muscle, what's going to happen? That's exactly what the movement is, right? So that's why it's important to know what the origin and insertions are. Okay, so for gluteus maximus, it's got a lot of proximal attachments. It's just everything that's like located like with the iliac crest, the sacrum, like sacrotuberous ligament. Yeah, I would note this, but he's not going to like test you, is it sacrospinous ligament or sacrotuberous ligament for the proximal attachment, right? So, I mean, it's probably honestly a little bit of both, but he's not going to test you specifically on that. I just note this proximal attachment generally so you understand the movement of it, right? The distal attachment, I think this is important, iliotibial tract, because we talk about two muscles that attach to the iliotibial tract. You have tensor fasciae latae as well as the gluteus maximus. So I would note that because that's something that's different, right? You have gluteus maximus as well as tensor fasciae latae, which are both going to attach to the iliotibial tract, right? It also attaches to the gluteal tuberosity. So this is a ginormous star, super ginormous star. It's going to be innervated by inferior gluteal nerve. The way like I like to remember gluteus maximus is inferior gluteal nerve. It's like it's the opposite of what you think. So for example, the gluteus maximus is like a huge muscle, right? But it gets the inferior gluteal nerve, like not the superior. Like that's the way I don't know. That's the way I always remember gluteus maximus. It's a huge muscle, but it gets like the inferior gluteal nerve, not the superior gluteal nerve. So I would note that because he can definitely test the difference between superior gluteal or inferior gluteal nerve. In regards to arterial supply, I would just note that it's superior and inferior. The reason why it's superior and inferior gluteal artery, just because it's just such a big muscle. It's getting arterial supplies from lots of things, basically. So superior and inferior gluteal artery. So I would note that. So if you know, like, for example, that the gluteus maximus attaches to the iliotibial tract and like the gluteal tuberosity of the femur, then you would be like, okay, in your head, if I contract the gluteus maximus, right, it's going to help with a little bit of like lateral rotation, because when you pull here, it's going to help like turn the leg basically a little bit, right? Or like it's going to help like kind of like pull out or turn the leg a little bit. That's like its minor function. But the major function of like the gluteus maximus is extension. So for example, when you're standing up, right? So from sitting down to standing up would be extension. When you're coming out of a squat, right? So when you're on the floor from a squat and you're coming up, for example, that's going to be really important movements for the gluteus maximus.
What origin did you say to use for that?
So for the origin for the gluteus maximus?
Yeah.
I mean, I would note these like for example, the posterior crest, the posterior gluteal line, the sacrum. I mean, they're all generally in the same area. So as long as you know like these, like which ones are in the general area, I think you should be good in regards to the proximal attachment for that muscle.
Okay, cool, man. I just didn't know if you said to like pick one out, like specific.
No, you're good. I'm trying to see what's important, because again, like I said, like Muffley didn't teach these lectures last year, so I'm not too sure about like which ones he's going to test on. But knowing how Muffley tests, I want to make sure you guys are like fully prepared on like what I think is most important. You know what I mean? I don't want to like cut you short and be like, oh, don't study this, and then it's on the exam, for example, because he didn't teach these lectures specifically last year.
Yeah, I got you. Thanks.
Yeah, I got you. Okay, so that one's that. And then here is going to be is the tensor fasciae latae superficial, inferior to the gluteus maximus. I mean, the kind of just like the tensor fasciae latae is just on the lateral side of your body, so it's on the lateral side of your leg, and your gluteus maximus is on your posterior. But they both attach to the iliotibial tract, so which is going to be right here. So you could say like the tensor fasciae latae is lateral, and like the gluteus maximus is posterior. But that's all you need to know for that. Okay. So, and this is going to be the muscles of the gluteal region. So this is like a lot on one slide. But I broke it up like into like little slides after this just to make it a little bit more digestible. So he talks about all these things and like flies through them a little bit quickly, but I'm going to go through them like one by one a little bit throughout the next following slides. So we'll talk about the piriformis, the obturator internus, the gluteus medius and minimus. We'll talk about these, but they all are going to attach to the greater trochanter of the femur, which is why I said in the beginning, like, oh, like these attachments are important because a lot of muscles are going to be attaching to it. One of them is the greater trochanter, which would be important to note. So we'll get through the innovations later on, which are going to be obviously high yield. Okay, so for piriformis muscle, so like I broke it up into like little muscles. So for example, when he like puts like something like this, I like to make this, just to make something that's like super simple. So for example, like this is going to be everything that he said on that slide, but just in a picture. So for example, if I look at this and I'm like, okay, based on this picture, the piriformis attaches to the sacrum, right? And it's going to attach to like some part of the sacrum, right? And it's going to attach to the greater trochanter of the femur, right? Now I know the origins and the attachments just based off of this picture. Here it's, it's nerve to piriformis. Great. It's literally named in and of itself, right? And all you need to know is that it's inferior gluteal artery, mostly for the piriformis. So like we said, like where he put there, I like to just put like that because I feel like it's easier to like look at and like it's kind of like easier to study. Same thing like this one. The next one would be the obturator internus. This is going to be, so for example, I look at this and I'm like, okay, it's going to be, its origin is most likely going to be somewhere along the lines of the obturator foramen, right? Because this is the obturator foramen, so like the obturator membrane, like would be like located right here, and it's going to attach to the greater trochanter, right? Roughly around the greater trochanter of the femur. And like if you contract this muscle, it's going to pull and it's going to help with like lateral rotation of the leg, like so kind of like turning your foot outwards basically would be like lateral rotation. And an inferior gluteal artery, right? So this would be right here, right there. And then this is the gluteal muscles that he talks about. So here's the medius, the maximus, and the minimus. Obviously, he's not going to put a picture like this and test you on the exam. These pictures are just used to like help you visualize where the origins and like where the attachments are, just for you to best understand what's going on. But in regards to like the medius and the minimus, remember that's superior gluteal nerve. That's like super high yield. Like I would 100% know that the gluteus medius and minimus are superior gluteal nerve. And remember the gluteus maximus, that's a huge muscle, but it gets inferior gluteal nerve, right? So it's going to get the inferior gluteal nerve. So I would definitely note that. And then in regards to the arterial supply, remember the gluteus maximus is a ginormous muscle. So it gets arterial supply from superior and inferior gluteal artery. And then gluteus minimus and gluteus medius, these muscles are pretty high up, right? Which makes sense why they get the superior gluteal artery, right? They're only going to get the superior gluteal artery, right? So if you know where these muscles are located and you know where like these arterial supplies kind of go to it, it should make a little bit more sense as to which ones are doing what. Okay, so which structure is not supplied by the superior gluteal nerve? A, B, C, D, E, or F? Remember, not supplied by the superior gluteal nerve. I made this one a little bit tricky, but it's for the best for you all, so it can help you test which ones, so you understand which one's going superior and which one's inferior. Okay, so it is actually going to be A, right? So it's A. So which ones are not supplied by the superior gluteal nerve? That's going to be gluteus maximus. Remember, it's a ginormous muscle, but it's only going to get inferior gluteal nerve. The reason why I put tensor fasciae lata in there is because I don't want you to forget that superior gluteal nerve also does tensor fasciae lata. That was the first muscle we talked about. Remember, but it's going to get innervation from superior gluteal nerve. So remember, don't only note that gluteus medius and gluteus minimus are superior gluteal nerve, also note that tensor fasciae lata is also going to get innervation from superior gluteal nerve. So that's why I put A and D, because I knew like some people were going to put A and D because we forgot kind of like about the tensor fasciae lata. But the tensor fasciae lata is also going to get superior gluteal nerve. So I would use this as a study slide as well. Remember, gluteus maximus, inferior gluteal nerve. So, so we have the gluteal muscles here. So here's the gluteus minimus, excuse me. So yeah, you see how small it is, right? So it's pretty easy to point out because it's really small. The gluteus medius, which is going to be right here, it's a little bit larger. It actually reaches up to the iliac crest right here, up here. So it actually reaches there. So that's going to be the gluteus medius. And the gluteus maximus, you can't miss that. Like that's like a ginormous muscle, right? So this would be the gluteus maximus, which would be a main hip extensor. Like I said, remember the gluteus maximus is most important in hip extension, right? So like we said, like standing up, coming out of a squat, like for example, that's going to be your gluteus maximus, right? And then your hip abductors are going to be anything that's going to act on the femur but on the lateral side. So for example, like we said, the gluteus minimus and gluteus medius, once they contract, they're going to kind of pull the leg / thigh like outwards, basically. So it's going to abduct it, right? Same thing with the tensor fasciae lata, right? With the tensor fasciae lata. So those are going to be notes. So I would definitely note these.
Hey, Justin, quick question.
Yeah.
So when talking about gluteus medius and gluteus minimus, on his slide, he wrote the proximal attachment as anterior gluteal line and superior, and I wasn't sure what that meant. And then the other one was anterior gluteal line and inferior. What is the superior and the inferior referring to? Yeah,
so those are like little lines that are associated with, you can't see it on here because it's actually associated with the pelvic bone. So for example, the gluteus medius gets the anterior gluteal line and superior gluteal line, which is like up here. You can't obviously see it here because it's not showing the bone. And this one's getting the anterior and the inferior because it's like a smaller muscle, gluteal line. Does that make sense?
They're also gluteal lines as well?
Yeah.
Okay, and then real quick, where is the tensor fasciae lata in regards to this? Would that be like superior to the gluteus medius or like where?
So like, so the best picture to see that is going to be here because gluteus maximus we know attaches to the iliotibial tract. I mean, you can't see it too well here, but the tensor fasciae lata would be located right here.
Okay, and so the gluteus medius would kind of be underneath that a little bit, like.
The gluteus medius is actually underneath the gluteus maximus. So if I remove the gluteus maximus, I'll see the gluteus medius. If I remove the gluteus medius, I'll see the gluteus minimus.
Oh, okay. Alrighty. Thank you.
Does that make sense? Yeah. So like if you just put your arms straight down on the sides, your tensor fasciae lata is right there on the side of your leg, on the side of your thigh, excuse me. Does that make sense?
Yes. Thank you. Sorry.
No, got you.
Hey, Justin, I have a question.
Yeah.
So this slide is showing the movement for those muscles, but for the obturator internus and the piriformis, are those both lateral rotators?
Yeah, those are going to be helping with lateral rotation.
Okay, yeah. Thanks.
So is he going to give the bone? So again, like I said, he didn't give cadaver pictures last year at any of his lectures because we went to the cadaver lab to study like these like structures. So I'm not sure if he's going to give bone structures, but I would note the muscles even without the bone structures, just in case he doesn't give it to you. So you know what I'm saying? But I would still look at the bone structures because it's important, like I said, to note which ones are going to be attaching to which. For example, like I know this is gluteus minimus, right? Because it's really small and it doesn't reach up all the way to the iliac crest. Well, this is going to be gluteus medius because it reaches up all the way to the top. Well, gluteus maximus, remember, it gets like almost the entire sacrum, right? And it attaches over here to the gluteal tuberosity in the iliotibial tract. So I would note it just in case he posts a picture. I mean, I'm not even sure because, like I said, he didn't give us cadaver pictures last year. I'm just trying to make you guys as prepared as possible for anything like Muffley style questions, for example. So, yeah. Okay. Yeah. Okay. So he talked about Trendelenburg gait like really quickly. Like he didn't even put a slide on it. So I put like a little slide on it just to like note on it. Like again, like I want to just make sure I'm covering like all my bases in order to make you guys as prepared as possible. So he talked about it a little bit. So I put a little slide to understand what's going on. So for example, here's what he's talking about when he says Trendelenburg gait, right? So for example, in this image, you see a left hip drop, right? So for example, the left side of your hip is dropping. So right here, it's just dropping, right? Why is it dropping? It's dropping because the superior gluteal nerve on the right side is affected. The right side, that's important to note. So for example, that means that you're going to have a weak gluteus medius and a weak gluteus minimus. right? Also tensor fascia lata, but that's not the one we're talking about too much here, right? So you're going to have weak abductors on the right side. So that's important to note because it's going to be a contralateral diagnosis, which means a diagnosis on the opposite side, right? So for example, like I said, if I put a question and I say, someone has a left hip drop while they're walking, which muscle is most likely affected? Is it going to be the right gluteus medius or the left gluteus medius? Well, we know it's left hip drop, and it's going to be a contralateral diagnosis, meaning it's going to be on the opposite side. It's going to be weak right gluteus medius and minimus. Does that make sense? The reason why it's weak is because it's not putting tension on your hip anymore. And if it's not putting tension on your hip anymore, it's going to loosen up and cause left hip drop, basically. Does that make sense? Because these are super weak, it's going to cause left hip drop because it's not like tensing. It's not like pulling down to keep the hip aligned, basically. Does that make sense? All right. So I put like a little picture about that, basically, just for you guys to understand that. Okay, so remember, super important again to note what's going to be superior to inferior. Again, we have piriformis, right? So it's going to be piriformis. Then we're going to have superior gemellus. What comes in between that will be the sciatic nerve. Then we're going to have obturator internus. You can't see it too well here, but it'll be right here. Then you're going to have inferior gemellus, and then you're going to have quadratus femoris. So again, super important to know what's coming down from superior to inferior, because when we talk about the nerve supply, it'll make a lot more sense. So for example, like the superior gemellus actually gets the nerve to the obturator internus. Like why, I don't know why they would name a nerve after one muscle when it still innervates another muscle, because that's obviously confusing. But knowing that which one is going to be superior to inferior is going to help. So for example, we have the obturator internus, which is, let's just say it's right here, obturator internus. The muscle that is superior to the obturator internus is going to be the superior gemellus. So the superior gemellus gets the nerve to the obturator internus. So the obturator internus obviously gets the nerve to the obturator internus, as well as the muscle above it, which is going to be the superior gemellus. It's the same thing when we talk about the quadratus femoris. So for example, here's the quadratus femoris, right here. You have nerve to quadratus femoris. Okay, great. That makes sense, right? It literally says it in and of its name. But nerve to quadratus femoris is also going to innervate the inferior gemellus, which is the muscle right above it. So you see what I'm saying? So the nerve to quadratus femoris innervates the quadratus femoris, but it's also going to innervate the muscle above it, which is the inferior gemellus. The nerve to obturator internus innervates the obturator internus, but also gets the muscle above it, which is going to be superior gemellus. So remember, if you note which ones are going to be superior to inferior, you'll never get the innervation wrong, because you know, okay, nerve to whatever, it's also going to get the muscle above that. So nerve to quadratus femoris, it's also going to get the muscle above that, which is inferior gemellus. Nerve to obturator internus, okay, it's going to get the muscle above that, which is superior gemellus. Does that make sense? Okay. So sciatic nerve, like we said, typically comes between the superior gemellus and the piriformis. Okay, so here are the short rotator muscles of the hip. So again, I put this image because I think it's way more clear than this image in regards to where they are. So again, we have piriformis, right? Then you have superior gemellus, obturator internus, which would be located right here, right? Obturator internus, inferior gemellus, and quadratus femoris. So just at looking at this picture, I can know exactly what the origin and attachments are, right? Like these are going to be mostly the greater trochanter of the femur. Piriformis is going to get the sacrum, right? Superior gemellus will get the ischial spine, which is located right here. So they go to the greater trochanter. Obturator internus is just going to get like the inner obturator membrane. It's going to go over here. Inferior gemellus is going to get ischial tuberosity, and then you have quadratus femoris, which is just going from the ischial tuberosity to like the kind of like intertrochanteric crest area. But yeah, this picture is just to help you like organize which ones are going to be from superior to inferior in regards to attachment as well. So again, I'm reiterating what I said earlier. You have like a gemellus sandwich. I guess that helps you remember, because you're going to have piriformis, superior gemellus. Then you're going to have obturator internus, inferior gemellus, and then quadratus femoris. So gemellus sandwich because you have superior, inferior gemellus, and in between that is obturator internus. So again, nerve to obturator internus. Okay, I know it gets the nerve. I know it gets the obturator internus, but it's also going to get the muscle above that, which is the superior gemellus. Okay, So nerve to quadratus femoris. Okay, I know it's going to get the quadratus femoris, but it's also going to get the muscle above that, which is going to be the inferior gemellus. So this slide is to help you like understand what's going on and how you understand which muscle is going to be innervated by which. Okay, so which of these structures do not go through the greater sciatic foramen? A, B, C, or D? You're all going to be pros about which ones go to the sciatic foramens by the end of this lecture. Okay. So yes, it is going to be D, none of the above. Very good job. Sciatic nerve, piriformis, as well as pudendal nerve are all going to go through the greater sciatic foramen. But note, remember, the pudendal nerve comes back through the lesser sciatic foramen. So yes, really good job. We talked about these already. Remember, I put the image right here just to help you remember what these muscles do, obviously, and they're going to help with lateral rotation. Okay, so here are going to be the hip rotators, but in regards to cadaveric images, right? So here's when we put our knowledge to the test, because this is going to be what they actually look like in, obviously, human bodies. So this is the piriformis, right? Going from the sacrum all the way to right here, like the greater trochanter area. So that's pretty easy to identify, right? This will be the piriformis, right? Coming right through the greater sciatic foramen, which would be located right here. Over here, we have the obturator externus. So externus, because it's going to be on the outside, like on the outside of the os coccyx, so the outside of the pelvis, right? So this would be the obturator externus, wrapping around and attaching right here. This muscle right here is still part of the obturator externus. This right here, this is obturator externus because it kind of wraps around, and this is going to be obturator externus, right there. So for obturator internus, it's the inside, right? This is going to be the inside of the os coccyx or the pelvic region, right? This will be the obturator internus, getting some of the obturator membrane, going through right here, the lesser sciatic foramen, right here. This is going to be the obturator internus, right here. This is the piriformis. This is the obturator internus. And this right here is still going to be the obturator externus, right? Which would be right here. This is the same thing as that, this and that. So again, piriformis, obturator internus, this whole thing. And then this is going to be obturator externus, the posterior portion. And then this Justin, one with, yeah.
Is that picture a posterior view?
Yeah, this picture right here is a posterior view.
No, the second picture of obturator externus.
Oh, this one right here?
Am I looking posterior?
Yeah, these are going to be posterior. So yeah, this is going to be a posterior view.
Okay.
Yep, gotcha. Okay, and then for this one, which is a little more confusing, you might have to like zoom in, but this is going to, when you obviously get this, zoom in on your lecture, but this would be the piriformis, right? This muscle. This muscle right here, I'm going to go really slow, but this muscle right here, that one, this one right here, it's really hard to see, but that one is the superior gemellus. This entire kind of triangle thing right here, this thing, is the obturator internus. Obturator internus, right here, this thing. This right here, this little muscle, this one, is the inferior gemellus. Inferior gemellus. And then this right here will be the quadratus femoris. I know it's super hard to identify, which is why I made another slide on it in order to like zoom in or make it huge so like you can identify which ones are which. But that's going to be after this question. Okay, so which muscle is labeled by the pink arrow in its innervation? I want to give you guys the hardest ones, or like pretty hard questions in regards to identifying, just because so we can talk about it a lot more during the lecture and clear it up for you all. So is it going to be inferior gemellus? Yeah, is it going to be A, B, C, or D? I mean, you can feel free to read that. But if you remember the order, remember from superior to inferior, this should be able to help you understand what the innervation is and which muscle that is. Oh yeah, you guys are doing really well in this question. Okay. Cool. All right, so it is going to be, yes, C. Oh, wow, I meant to take that box out, but it's okay. Yes, it's going to be inferior gemellus, right? So this right here is going to be the inferior gemellus, and it's going to be supplied by the nerve to the quadratus femoris. Remember, nerve to quadratus femoris gets the muscle above it, which is the inferior gemellus, right here. Nerve to obturator internus gets the muscle above it, which is superior gemellus, right? So I put this right here in order to help you identify which muscles are which, right? So the yellow right here, this is going to be piriformis. This red right here is going to be superior gemellus. This little muscle right here. This is superior gemellus. This little blue one, or this blue, light blue, is obturator internus. This purple is going to be inferior gemellus, and this green right here is going to be quadratus femoris, right? So I made the picture really big and then like circled these things so I can help you all identify, because they kind of like look like a mush together, but they're actually going to be separate muscles. So I identified that for you all to help you in regards to that.
Thank you so much.
Yeah, I got you. And then I also put like a little chart for you guys in order to remember the nerves, because I feel like innervations are just the highest of yields. And when it comes to anything, just because like nerve supply is always like almost always consistent, super testable, which is why I put like a little thing here. So superior gluteal nerve, remember tensor fascia lata, gluteus medius and minimus. Inferior gluteal nerve is going to be gluteus maximus. Nerve to obturator internus gets obturator internus and the muscle above it, which is going to be superior gemellus. Nerve to quadratus femoris gets the quadratus femoris and the muscle above it, inferior gemellus. And then you have nerve to piriformis, which is going to be the piriformis, which is why I just put like a little chart, because it's like he throws in all the nerves in there, but I wanted you guys to get like a little chart to understand which ones are like going to which muscles. All right, gluteus medius and minimus. I mean, we know they're important for abduction, which we talked about. But yeah, they're also important for medial rotation. Just the reason why they're important for medial rotation is because if you actually look anatomically where the gluteus and minimus actually attach to on the femur and where they're located, it's kind of like in front of the femur, so it kind of like pulls the femur and turns it medially. That's if you wanted to look at a cadaver picture or like another image to help you understand that. But the gluteus medius and minimus are going to help a little bit with medial rotation, but the main function is going to be abduction, which is like taking away from the midline, right? So abducting, abduction. This I had no idea what this was. I mean, he's not gonna test, like he's not gonna put this image on the exam, no. But this just confused me. This was basically, he just said Trendelenburg gait, which I already put like a slide on that in order to help like the hip drop. So like just refer to that. This I don't know. I guess he's just saying that this is going to be like lateral rotation of the foot, because when you turn your foot outwards, it's lateral rotation. But when you turn your foot like inwards, that's going to be like medial rotation, right? So I would just know that. But this just kind of looks like a dude dancing, but I think that's about it. Okay. And then for the gluteal region, the most important thing I would say, which I put on the next slide, is going to be the injections. Yeah, so whenever he says something on lecture, I like to put like a little slide on it. Like it doesn't have to be like super extensive, but like really brief, just for you to like remember like the important things that he says. Because so for example, he talked about this in lecture, but he never wrote it down, right? So for example, the most important spot to put the gluteal injection is laterally and superiorly, right? He said that in lecture, which is why I was like, oh, he doesn't say it here, obviously, but he said it in lecture, which is why I wrote it down in his own slide, right? So it goes laterally and superiorly. So it's going to go from the lateral side of the leg and the superior portion, that little quadrant right here, which would be located right here, lateral and superior. The reason why you put a gluteal injection there is because you don't want to hit the superior or inferior gluteal nerves, because the more medial you go or the more inferior you go, your chances of hitting the sciatic nerve, the superior gluteal nerve, or the inferior gluteal nerve are very high. And obviously, the last thing you want is a gluteal injection puncturing your sciatic nerve, right, or your superior gluteal nerve. That's obviously what you don't want, right? So remember, laterally and superior. I would note that. That's why I bolded that. Where would you want to put a gluteal injection? On the lateral side and the superior side. Okay. So he talked about the sciatic nerve and then superior gluteal nerve in regards to what they innervate. So sciatic nerve is just going to get like the entire posterior compartment of your thigh, like almost, yeah, like every muscle in the posterior compartment of your thigh is going to be sciatic nerve. So semimembranosus, tendinosus, biceps femoris, even the posterior part of the adductor magnus. We'll talk about this when we get into like the next lecture. But in regards to this, we have this is going to be the sciatic nerve. I know it's a little hard to see from this like far view, but he's basically pointing at this structure, this ginormous structure. This is the sciatic nerve, right? He's not gonna like put this picture here, like this picture, and then be like, am I pointing at the inferior gluteal nerve or the sciatic nerve? Obviously, you'd have to zoom in like 2,000 times to see if he's pointing at this or if he's pointing at like the ginormous structure. Most likely, if he's pointing like this, he's pointing at the sciatic nerve. If he zooms in like this, you see this little nerve right here? This one right here, this tiny little nerve, that's actually going to be the inferior gluteal nerve. The inferior gluteal nerve. Does anybody remember where the inferior gluteal nerve is going to supply?
Gluteus maximus.
Yeah, gluteus maximus. Yeah, so it's going to supply the gluteus maximus. Yeah. And then here's the superior gluteal nerve. Right, superior gluteal nerve, which is like located right here. And then you have, this is inferior gluteal nerve, and this ginormous thing is the sciatic nerve, right? And then this would be like the piriformis, right? Which is the sciatic nerve is going just inferior to that. They obviously removed all the other muscles there, so you can only see the piriformis there. And again, he put a chart, but I mean, I gave you guys a chart already in order to memorize. The superior gluteal is going to give, or is going to supply the gluteus medius and minimus, as well as the tensor fasciae lata. Like, don't sleep on the tensor fasciae lata, because that's the one, like, obviously you can like categorize the medius and minimus. Okay, that's superior gluteal nerve, but don't forget the tensor fasciae lata is also going to be superior gluteal nerve. Inferior gluteal nerve is going to be gluteus maximus. Okay, so which muscles? So I put this little chart. This is just to help you remember again, like which muscles am I covering up respectively? So for example, we know the nerve to obturator internus is going to supply the obturator internus, and we know the nerve to quadratus femoris is going to supply the quadratus femoris. But what are the other muscles that they supply? Is it going to be superior gemellus, inferior gemellus, or is it going to be inferior gemellus, superior gemellus? So is it A or B? I just put this in here just to hone in on that you guys don't get confused between which muscles are getting which. Right? And then you can also obviously use it to study in order to test yourself when you're going through the notes, right? All right. So yeah, I think everybody has a good consensus on it. It is going to be, yes, A, superior gemellus and inferior gemellus, right? So obturator internus, the muscle above it, superior gemellus, quadratus femoris, muscle above it, inferior gemellus. Yes, really good job on that, yo. Okay, so here's a cadaver picture. So if you sever the nerve supply of this muscle, which other muscle would be affected? So this muscle right here. Right. This one. Which other muscle would be affected? Okay, I'll give you a few more seconds. See which other muscle. So yes, everybody seems to have a consensus. Is going to be yes, gluteus minimus, right? Because right here, remember, this is going to be the gluteus medius, right? The reason why I know that is because it goes all the way to the iliac crest. The gluteus minimus doesn't do that. So the gluteus medius is going to go all the way up here. Right, and we know it's not the gluteus maximus because the gluteus maximus, like you can't miss it. It's like ginormous. So this would be the gluteus medius, which is why I asked which other muscle would be affected. If we know that the superior gluteal nerve is going to innervate the gluteus medius, then we know that the gluteus minimus will also be affected. But also note the tensor fasciae lata will also be affected as well. So note that too. So inferior gluteal nerve palsy. So again, yeah.
I have a question. That last question that you just gave, is that like a way that it would show up on the test? Like, is this a good like exam kind of question?
So I mean, I feel like it's a good exam question. Again, like I said, he didn't give cadavers last year, so I never got any exam questions based on cadavers. But based on how Muffley teaches, this is going to be a second, obviously, hand question, so you have to know what muscle it is and what it innervates. So I would say this is definitely on the lines or on the track of what could be tested. He can obviously also test on what is that, obviously, which is just like pointing out a structure, but he can also test in regards to this, which is why I'm trying to give you a little bit of both.
All right, thank you.
Yep. Okay, so for inferior gluteal nerve palsy, that's just basically you can't stand up, obviously, because inferior gluteal nerve is going to supply your gluteus maximus, right? If you're losing the supply to your gluteus maximus, your extension of your hip is going to be highly, highly compromised, right? So meaning you can't stand up, you can't climb as well easily, you can't come out of a squat. Like that's going to be in regards to what inferior gluteal nerve palsy is, right? So I mean, it says what it does in and of its name. So if you know the inferior gluteal nerve supplies the gluteus maximus, then you know what's going to happen if you like sever that nerve, right? So vascularization, like I said, we've talked about this before. External iliac turns into femoral artery. Femoral artery is going to give the deep femoral artery, which is going to do the posterior side of your leg, right? So the posterior side of your leg, remember, will be sciatic nerve as well as deep femoral artery. And then we have femoral artery is going to continue down, right? And it's going to turn into popliteal artery. And then once it passes the adductor hiatus, and then it's going to split into anterior and posterior tibial artery, which we'll talk about more later on. Note, this is just a future note because we'll talk about it more, but just note that the posterior tibial artery is going to give off the fibular artery. This is going to be more important when we talk about it later on throughout the next lecture and the lecture after that the posterior tibial artery gives off the fibular artery. Because you can see right here, because you branch off into anterior and posterior tibial artery, the posterior tibial artery gives the fibular artery, also known as the peroneal artery. Okay, so here's this picture again, and I'm just going to put this again just for you guys to use for your studies. We went over this, so I won't go over it again. Again, so for cutaneous innervation, this is, I mean, it says it in and of its name, so it helps us. So for example, like lateral femoral cutaneous, it gets the lateral side of your thigh and it's cutaneous, right? So, I mean, it says it in and of itself, so that helps, right? Obturated. We know the obturated nerve is really, really important in motor, obviously. So motor, so being for the medial side of the thigh. So all of the adductors are going to be obturated nerve, but it also has some sensory innervation, which makes sense as to why it gets the medial portion, right? Because the obturated nerve is mostly going to supply medial motor muscles. It's also going to do some medial cutaneous, right? And then posterior femoral cutaneous, posterior side of the thigh, and it's going to give you cutaneous innervation, right? So if we know what these things stand for, then we should just know like exactly where they go and what they supply, right? And then remember dermatomes, he said not to worry about those. This again, I just put this in a simpler version right here. We've talked about this already. I'm not going to go over it, but this is going to be helping you just to study in regards to what's going on, because I felt like this is just a lot to look at, so I just put it like that. Okay, so remember, like I said, I think when it comes to exams, I think the most important things are the differences, right? So, for example, like semimembranosus, semitendinosus, biceps femoris, they're all going to get perforating branches of deep femoral artery. They're all going to be attaching to the ischial tuberosity. But like we said, so that's all going to be like similar things to these muscles, right? Most of the things that are most testable are going to be things that are differences, right? Usually they're going to test things that are based on differences, right? So, which is why I labeled them on the next slide. So like I put the major differences between the hamstring muscles is going to be that the semitendinosus and the semimembranosus, its distal attachment is going to be on the tibia, which means they're going to be more medial, right? So they're going to be more medial. So the semitendinosus and semimembranosus are going to be more medial, and they attach around the tibia, basically. The innervation is going to be the tibial portion of the sciatic nerve, which makes sense. If we know where it goes to, then we know it's tibial portion of the sciatic nerve. Biceps femoris, its distal attachment is actually going to be on the fibula. So we know the biceps femoris is going to be on the lateral side of your hamstring muscles, right? So it's going to be on the lateral side, which is over here, lateral side, right? And then innervation is going to be common fibular portion of sciatic nerve, right? Because the fibula is on the lateral side. So we would assume that the common fibular portion of the sciatic nerve innervates the biceps femoris, right? Also, I would say it's a little bit important to note that the short head of the biceps femoris attaches to the linea aspera, which is just a line that's on the posterior side of the humerus. So basically, it's short. It doesn't go all the way to like the hip, basically. It doesn't go all the way to the ischial tuberosity. And then the long head of the biceps femoris actually goes to the ischial tuberosity, right? The short head does not. So I would note those major differences. here, just know the femoral artery runs through the adductor hiatus and turns into the popliteal artery. I would say that's important. Eventually, when we start talking about that a little bit more, that's it's going to be, yep. Okay. And then here, I just labeled it just to make it a little bit more clear as to what he was pointing at. So for semimembranosus, that's going to be this muscle located right here with this kind of like purplish pink arrow. Semitendinosus, I put this arrow right here just to help you identify that this muscle right here is the semitendinosus, this one. And then over here, when he's talking about the biceps femoris, this is the long head, which is going all the way to the ischial tuberosity. And this is the short head, which only goes to the linea aspera. So it kind of stops like right around here, basically. So I just put those arrows in there to help you make it a little bit more clear. Okay, this popliteal fossa is 100% high yield. I would know this for sure. But if you know, like, for example, if you know where these muscles are, the borders are going to make like perfect sense. For example, like, so like, you know that if you know that the semitendinosus and membranosus are going to be on the medial side, right? You just have to know that they're superior, right? This popliteal fossa is just going to be like that little posterior portion behind your knee, right? So I would note that like all these borders, right? That the biceps femoris is the lateral superior, and that the middle inferior and lateral inferior will be medial and lateral, medial and lateral heads of the gastrocnemius, right? Which would be located right here. So I would note these. I would 100% note these in regards to their borders. I would also note their contents as well generally, but I mean, it says popliteal artery, popliteal vein, which is obviously makes sense because it's the popliteal fossa. Sciatic nerve, because we know it goes down the posterior side of the leg. And then he didn't talk too much about the sural or the calf nerve. That's just going to be during sensory innervation on the posterior side of the leg, but he didn't talk too much about that. So I would note those borders. Those borders are important. Okay, and then this, just know that medial rotation is turning the foot in, lateral rotation is turning the foot out. And then that's it for that lecture. Okay.
Quick question before we move on.
Yes.
So the semitendinosus is more medial than the semimembranosus.
It depends where you're talking about, like in regards to like, because it depends like where exactly you're talking about. Because for example, when it's proximal or its distal attachment, like which would be, like over here, it's just like the semitendinosus, its distal attachment is going to be, you could say like superficial to the semimembranosus, right? Because when we talk about it in the next lecture, the pes anserinus, which is going to be like when he said like that goose thing, that's going to attach like the sartorius, the gracilis, and the semitendinosus. The semimembranosus is kind of like a little bit deep to that. So like it really like depends into like what you're talking about. I mean, over here it might be slightly medial.
Okay.
It just depends on what portion of the muscle you're talking about.
Okay, yeah. The reason I was asked is because on slide 35, it looks like the semitendinosus is more lateral, but then on the other ones, it looks like it's more medial. So that's why I was like a little lost.
Yeah, it's a little confusing.
But I see what you're saying.
Mm-hmm.
Okay, thank you.
Yep. Okay, and then that's going to be that for that lecture. Okay. Any questions? Anybody have any questions that you want to ask? So this might go a little bit over time, but I want to make sure you guys obviously again are getting the best out of these sessions and making sure you're learning the information. Okay. Do you remember which nerve he was talking about during lecture when he mentioned that hitting your crazy bone in the arm and the ulnar nerve was different in the leg? Was it? Oh, it was the common fibular nerve. So when he was talking about like the briefcase nerve, like you hit like your briefcase on your leg by accident, it's actually hitting your common fibular nerve. So that's what he was talking about when he brought that up in class. I was going to put that on the slide, but then I started looking up briefcase nerve and then nothing came up. And I was like, okay, maybe he just made that up. I don't know. So then I didn't see anything, so I just didn't put it on there. But yeah, it would be the common fibular nerve would be that. Okay. So we're going to go over this lecture, which is going to be anterior and medial thigh. Yeah, I had a problem looking it up too. Like I was just like, wait, there's no such thing as that. A briefcase, what are you talking about? So yeah, I didn't find anything, which is why I didn't put anything. But I mean, now you guys know it's common fibular nerve, right? Okay. Can everybody, wait, am I still sharing my screen? Can everybody see the screen? Yeah. Okay. Good. Let me get my little laser pointer. Okay. Does anybody need a break? Do you guys want a few minutes break?
UTL region.
It's showing the last part of lecture 7 for me.
Oh,
yes.
Okay.
Yeah, hold on. Your last slide.
Yeah, I'm in the wrong. Let's see. Okay. Okay, let's see. Oh, yeah, let me remove this. You guys can see that little box right here in the corner.
No.
Oh, no? Oh, okay. Let me get my laser pointer. Okay. All right, we'll keep going then. Let me drink some water. Any questions before we start? All right. So we're going to talk about the anterior and medial thigh. So we'll talk about it's leg muscles, attachments, innervation. We'll go through all those throughout this lecture in order to make these a little bit more clear. Yeah. Okay, so here's the little lumbosacral plexus again. Again, like I said, it's important to know where everything is in regards to the psoas major. I think that's a little bit important. He talked about it in class. So for example, the genital femoral is going superior to the psoas major, and then you have the femoral nerve, which is going to be lateral, and an obturator nerve, which is going to be medial, right? This is just a lot of lines, but I would also note, wait, let me just do I have this on the next slide? Yeah, okay. This makes my eyes a little bit better. So I would also note the branches, like genital femoral, lateral cutaneous, femoral, obturator. I would note these branches as well. We talked about the superior gluteal a lot and the inferior gluteal a lot in the last lecture. And again, just to remind you a little bit, wait, are you seeing the lumbosacral plexus, or is it on the old slide?
No, we see it.
Oh, okay.
Yeah, we're seeing it.
Okay. I would also note that the posterior femoral cutaneous, again, remember, inferior cluneal nerve comes off the posterior femoral cutaneous. Does anybody remember what the superior and middle cluneal nerves come off of?
Dorsal primary ramus.
Yes, dorsal primary ramus, yeah. And that's also going to supply the deep back muscles. So yeah. And then we have pudendal here as well. Okay. So cutaneous innervation. Again, we talked about this in the last lecture. Remember, if you just know what these words stand for, then you would understand where they're exactly supplying. So lateral femoral cutaneous, lateral side of the thigh, obturator, when we'll talk about in this lecture, is going to do a lot of the medial, and then posterior femoral cutaneous, which is just going to do the posterior side. Right? Dermatomes he said not to worry about, so I'm not going to talk about them. Here, I'll note the branches of the femoral artery, which is why, oh, I thought I put it. No, I didn't. Okay, well, we talked about it already. Remember, external iliac turns into femoral artery. Femoral artery is then going to branch off into deep femoral artery right here. So you can see external iliac turning into femoral artery. Then deep femoral artery is going to be branching off on the backside, right? And then femoral artery continues down and is going to turn into popliteal artery, et cetera, et cetera. And then also important to note, remember, obturator artery comes off of the internal iliac, right? Remember, like I said, the external iliac doesn't want any business with the gluteal region, right? The external iliac is just using the highway just to pass along, right? So the obturator artery is actually going to be coming out of the internal iliac, right? So I would say that's important to note. He even states it here. So internal iliac. All right. So which artery supplies the posterior thigh? So is it going to be femoral artery, obturator artery, perforating branches of deep femoral artery, or is it going to be a little bit of B and C? So this is just a startup comprehension check question. Okay, so, yep, everybody seems to have a consensus here. It's going to be the perforating branches of deep femoral artery. That's just to get your mind flowing. This is going to be the posterior thigh. Obturator again, remember that's the medial thigh. And then femoral artery is mostly going to supply the anterior portion of the thigh. So again, I put a little arterial supply summary here just to help you all out. Remember, femoral artery from the external iliac, but it's basically just an extension of it, right? The obturated artery from the internal iliac, perforating branches of deep femoral artery that's coming off of the femoral artery, which obviously is an extension of the external iliac, right? So I put like a little slide here just to help you remember those. Okay, so he talked a little bit about these arterial supplies. So remember when we talked about anterior and posterior circumflex humeral, like located in the humerus as part of the axillary artery, it was those branches. You have the same thing in the leg, right? So you're like, okay, great. The reason why we have that is because the femur is like highly mobile, right? So we want to have arterial supplies that don't get cut off. For example, if you're like sitting down for too long, like you don't want to, because you're flexing your thigh, if it gets cut off for too long, you don't want to lose supply to your entire leg, right? So this is why you have your like lateral femoral cutaneous as well as your medial femoral cutaneous. Oh, excuse me. Lateral femoral circumflex, Lateral femoral circumflex and medial femoral circumflex. So it's basically the same thing that you have in your humerus, right? I would note though that these are going to be coming off the deep brachial artery. So again, remember we have external iliac, which turns into femoral artery. Femoral artery is going to give the deep brachial artery. The deep brachial artery gives off the lateral and medial femoral cutaneous. So I would note that. Yeah, this is why I put like a little.
Do you mean
green.
femoral or brachial?
I saw brachial.
Oh yeah. Okay. Yeah. It's femoral. Yeah, I just put brachial probably because I was thinking about like the arm because it's basically the same exact thing. But no, yes, I'm gonna fix that. It's gonna be femoral. Yeah, it's obviously not brachial. We're not on the arm. Yeah, so it's going to be, yeah, my bad for that mistake. It's going to be deep femoral artery. Yep. Let me remember to start that so I can fix that. Okay, so yeah, I would say that's the most important thing to note on this slide. And then genicular arteries, those are just going to be anastomoses around the knee region, right? So genicular arteries will be located there. Okay, so for this is definitely going to be, I would say, yeah, this is high yield. Yeah, this is 100% testable. So I would remember these borders, and you're going to have, which would be located right here. This would be the femoral triangle. So you have superior is going to be the inguinal ligament, which is located right here, inguinal ligament. Lateral is going to be the sartorius, and then medial is going to be the adductor longus, right? It's going to be the adductor longus. I put this green little note here just to help you remember because he's going to talk about the floor later on. I don't know why he didn't put it on one slide, but I wanted to put it on this slide as well to help you remember that the floor of the femoral triangle is the iliopsoas as well as the pectineus. So knowing these borders and the floor is super important. So if you know, like, for example, like the sartorius, like we said, it kind of just like comes across your leg from lateral to medial. That'll help you remember that this is going to be the lateral border. Okay. So and then he also brought this up in class. He talked about navel, which is basically just saying that if you access the femoral triangle, right, going from lateral to medial, so going from this side to this side, you're going to have femoral nerve, femoral artery, vein, femoral vein, and then lymphatics, right? So which is why it's like nerve, artery, vein, and lymphatics, right? So that helps you remember which ones are going to be lateral and which ones are going to be medial. I put that on there because he talked about it. He didn't put it on his slide, but I wanted to make sure we had that covered. So yep, and it's going to that's exactly what it contains. Is going to be navel. Okay. Okay, so after all these things pop up, okay, so the subsartorial canal. So I put like a little image on the next slide because I felt like this was just, I guess, like a lot going on here. It kind of confused me a little bit. But I'm going to talk about this, exactly what's on this slide, on the next slide, which is basically just showing the subsartorial canal. So subsartorial is going to be just behind the sartorius. So you can see this is your sartorius muscle, just coming across, kind of like a seatbelt, right? It's kind of like, it looks like a seatbelt kind of thing. So kind of coming across your thigh. And then the posterior, or the deep portion of that, is going to be the subsartorial canal. It's going to be running from the apex of the femoral triangle, which is right here, right? This is our femoral triangle. The apex, which is right here, this is where the subsartorial canal starts, and it goes all the way to the adductor hiatus, which we'll talk about when we get into the later parts of this lecture. The contents, I would note those. High yield is going to be femoral artery and vein, saphenous nerve, which is just a nerve that's going to be branching off of the femoral nerve, and then you also have the nerve to vastus medialis, which makes sense, right? Because this is going to be more towards the medial side of the leg, right? That's why it makes sense it's going to be nerve to vastus medialis, right? Because this subsartorial canal is more so on the medial side of your thigh, right? So I would note the contents on here. It's definitely testable. I would also note saphenous nerve because he never talks about that. And it's going to be part of the subsartorial canal. So I would note that when you think about saphenous nerve, think about that's part of the subsartorial canal, as well as the other contents. So I put this little image just to help you understand where this actually is located, which would be right here, right? Because we removed the sartorius. So here's another comprehension check question. So what is the medial border of the femoral triangle? So is it going to be A, B, C, or D? Yeah, it seems like I'm not tricking anybody on this question. Nice. Okay, so I'll give you like one more second. All right. So yes, it's going to be your adductor longus muscle. So I use this, again, like I put these questions in these PowerPoints for a reason. Like I like to put questions that are not going to obviously only challenge you guys, but it's also going to help you use it as a study material. So for example, now you'll be able to use this question to study the borders again, right? Which would be right here, which is why I put this image here to help you study it. So the lateral border would be the sartorius. The medial border would be the adductor longus. The superior border would be the inguinal ligament, right? And then we'll talk about the floor later on, which will be the iliopsoas as well as the pectineus. But we'll talk about that when he brings it up later on in the lecture. Okay. He talks a little bit about the great saphenous vein, as well as the small saphenous vein. The only thing I guess I would note, which I put on the next slide, is that obviously the great saphenous vein goes to the saphenous hiatus, which makes sense. It's called saphenous hiatus, right, which is located up here. It's actually a little hole that's located like in your anterior superior portion of your thigh. It's a hole in your fascia, basically. It's not even a hole in your muscle. So basically, it's the fascia that's like covering your muscle. It's like a little hole, and like the great saphenous vein kind of just like goes right through it, right? And then basically, it's super superficial, basically. So your great saphenous vein is pretty superficial because it's on top of your fascia, right? So like on the next slide, you can see it right here, right? So you can see this fascia like covering all your muscles, right? The great saphenous vein is like, all right, I'm coming up basically, and it's just coming to the front side of it. So that you can see this is like the saphenous hiatus, and here's the great saphenous vein, right? So I would also note, I just put this on here just in case he was to talk about, or just in case it was a little bit important, but the great saphenous vein drains into the femoral vein. When we talk about veins, it's obviously the opposite direction. So when I say like great saphenous vein drains into femoral vein, I mean it's like the blood is going back to the heart, right? So great saphenous vein going back into the femoral vein. Just like how small saphenous vein drains into popliteal vein, which then drains into femoral vein, and then obviously goes all the way back eventually to the heart, right? So I would note these little things here, but that's about it. Here, again, he put these like arterial supplies and nerves, but I just put it again on the next slide. We've talked about these already. Remember, femoral nerve and femoral artery, anterior thigh. Medial thigh is going to be more so obturator nerve and obturator artery. And then posterior, remember, is going to be the perforating branches of the deep femoral artery, and then as well as like sciatic nerve, right? Okay, so which muscle or muscles attached to the iliotibial tract? This is going to be a question, a throwback question in the last lecture, just for you to remember. Yeah, I'll give you one more second. All right. So it is going to be, yes, E. The gluteus maximus as well as the tensor fascia lata are going to supply the iliotibial tract. Does anybody remember the innervation of the gluteus maximus and the tensor fascia lata?
Superior gluteal nerve and inferior, respectively.
So for gluteus maximus and tensor fascia lata are both going to be, actually, yeah, you're right, respectively, correct, yes. Because tensor fascia lata is going to be the superior gluteal nerve, yes, and then the gluteus medius is also going to be superior gluteal nerve. So yes, that is going to be correct. So gluteus maximus, remember, ginormous muscle, so the nerve is going to be inferior gluteal nerve, right? And then tensor fascia lata, as well as gluteus medius and minimus are going to be superior gluteal nerve. So yes, so I would categorize those as well. I like to refresh you guys in order to remember the innervations as well. So yes, good job. Okay. Oh yeah, so psoas and iliacus, right? So again, remember, so the psoas major and the iliacus eventually fuse together to make the iliopsoas muscle. So here's the psoas major, here's the iliacus, then they eventually like kind of like fuse together and attach to make the iliopsoas muscle. I think that's the most important thing here. Okay, so here's your psoas major, right? So it's pretty easy to identify. You see it attaches to your lumbar spine, basically over here. So this would be your psoas major. This is your iliacus, which is right here.
Justin, I had a question. Can you go back to the previous slide?
Yeah, of course.
He's pointing at those two nerves. Is that the femoral?
Yes. So, are you talking about these nerves right here?
No. I'm sorry. On that one.
Oh, this one. Yeah. Yeah. So this right here is the lateral femoral cutaneous. This one right here. And then this one right here is the femoral nerve.
And then the one at the thigh.
And then the one at the thigh, that looks like, it's hard to tell, but I think it's the same nerve as the lateral femoral cutaneous. But he's not gonna pick out those ones. But yeah, I hope that helps.
Thank you.
Yeah, I got you. Okay. Yeah. So psoas major right here, and then iliacus, right? So they're pretty easy to identify. Once you look at the pictures a few times, this would be the psoas major, and then this would be the iliacus, right? So iliacus right here. Oh, so yeah, he said, is there a question? Okay. So he said the floor of the femoral triangle. So he didn't bring it up until now, but I brought it up earlier just to get your mind like thinking about it. So remember, the floor of the femoral triangle would be the iliopsoas muscle and the pectineus muscle. So iliopsoas and pectineus will be the floor. Remember, the lateral border is going to be your sartorius, which is like your seatbelt. I think of it as like a seatbelt muscle. Then you have your superior border, which is your inguinal ligament. And then you have your medial border, which would be your adductor longus. The floor is going to be your iliopsoas as well as pectineus muscle. So I would note those. Those are important. Okay. Same thing over here. If I wanted to identify this on a cadaver, right, on a cadaveric image, I would see, okay, this is the inguinal ligament. So I know this is the superior portion of the femoral triangle. This is going to be your sartorius. You can't see the whole thing, obviously, but it's going to be eventually going down. And this would be your adductor longus, right? And then you have your psoas major or your iliopsoas, as well as the pectineus, right, which would be located in the floor of this triangle. And within this, you have your navel, right? Remember your navel, femoral nerve, artery, vein, and then lymphatics going from lateral all the way to medial, right? Okay, so which structure is not part of the subsartorial canal? So remember we talked about the subsartorial canal. Remember that was going to be, if you remove the sartorius, which structures are going to be located within that, or which ones is not, right? So is it going to be A, B, C, D, or E? Okay. Give you one more second. Okay. Yep, it's going to be B, the sciatic nerve, right? So remember we said the nerve tuberosum medialis, the saphenous nerve, the femoral artery, as well as the femoral vein are going to be all included in the subsartorial canal. So again, use this question to study because I put everything but. So now you know all these muscles that are the answer choices, not these muscles, all these structures that are in the answer choices are going to be part of the subsartorial canal. So yes, sciatic nerve is not part of the subsartorial canal. Good job. Okay, so same thing like we talked about from the last lecture. When he puts like a bunch of like muscles on one slide, I like to divide them up into like individual slides that are super, super simple. So we'll talk about iliopsoas, sartorius, as well as pectineus. But remember, when he puts these little F, and FOB, those are going to be the nerve supply, right? So femoral nerve gets iliopsoas as well as sartorius, and then the pectineus is going to be femoral and obturator nerve, right? So it's going to be obturator nerve as well. So I would note this for pectineus because pectineus is also, it's associated with the medial portion of the thigh. So it's kind of like, it mostly helps with adduction, so adduction. So it does get obturator nerve, but it also gets some portion of the femoral nerve. So I would note that as well. And in this, I put a huge star here because the sartorius is a 2-joint muscle. It's going to be a 2-joint muscle because it attaches to the ASIS, which is the anterior superior iliac spine, and it's go all the way to your tibia, right? So it's going to cross your hip joint as well as your knee joint. So your sartorius is a 2-joint muscle. I would note that. So here we go. So everything he put here, I just put like into simple slides. Yeah, the ASIS is the anterior superior iliac spine. Yeah, okay. Gotcha.
Justin, what did you say about the pectineus again? Sorry, man, I was writing.
No, you're good. Yeah, so the pectineus, like we know, is going to be in the medial side of your thigh, right? So it's mostly associated with adduction, so adduction. It's also going to help with a little bit of flexion, right, because of its angle when we see in cadaveric images. But the pectineus also has femoral nerve. So that's important to note because remember we said femoral nerve is associated with all the anterior thigh, right? And then we're like, okay, obturator nerve, all medial thigh. But pectineus is also part of the medial thigh, but gets obturator as well as femoral, right? So I would note that too because he put it here. It's kind of like an odd one out type of thing. You know what I mean? So I would note that.
Got it. Thanks, man.
Yep. So here's going to be like the super like simple images. So like I basically put what he like had there onto like slides like this. So you see like the psoas major, right? Looking like that. And then you have the iliacus, which then eventually come together and they're going to basically attach to the lesser trochanter, right? So it's going to flex the thigh at the hip and externally rotate the thigh at the hip. That makes sense, right? So if I pull these two muscles, you guys understand when I say like pull, right? It's kind of like contract, like it's kind of like pulling it this way, pulling it that way. So you're going to see it's going to flex this. So it's going to flex the femur, right? That's what the iliopsoas does. And it does a little bit of external rotation because you can see it attaches to this lesser trochanter, right? External rotation is the same thing as saying lateral rotation, right? So when you turn your foot outwards, basically, that's going to be lateral rotation, also known as external rotation. You see how it's like attached to the back side of the femur, right? Kind of like the back side of the femur. If you pull the muscle, right, you can assume that it's going to kind of like laterally rotate it as well. You all can see that, right? So if you pull it, it's going to help with a little bit of lateral rotation as well. But its most important action is going to be flexing the thigh at the hip. And it's going to be innervated by femoral nerve, right? So you see I put everything that he put on this slide into like a little slide like this to make it easier to understand the actions. Here's the sartorius. Ginormous, no, it's a 2-joint muscle. I would know that for sure. It's going to be a 2-joint muscle because it attaches to the ASIS, which is the anterior superior iliac spine, right? It's like your seatbelt muscle, and it's going to attach to your pes anserinus, right? So pes anserine or pes anserinus. I also noted here, because we'll talk about it later on, that the gracilis as well as the semitendinosus will also be attaching to the pes anserinus. So I would note that. I'm giving it to you a little early on, just so like it, just so you get like your mind going before we start talking about the pes anserinus. But in regards to the action, right, it's going to flex the thigh at the hip. It's going to help with abduction, so abduct, so pull away basically the thigh at the hip. And it's also going to help with lateral rotation of the thigh, and it's going to flex the leg at the knee. So, for example, like if I look this image, right, and I pull the sartorius muscle, right? First thing I know it's going to do, it's going to flex this thigh, right? So it's going to bring your femur up, right? That's flexing the thigh at the hip, right? Because it's obviously pulling up, right? So it's going to flex the thigh at the hip. It's going to abduct the thigh at the hip as well, right? Because it's going to basically be pulling, but it's pulling towards like this side basically. So it's kind of going to pull the thigh away, right? Does that make sense? You can see it kind of because the attachment's more so over here. So it's going to kind of be pulling the thigh or abducting it. Lateral rotation. The reason why it's lateral rotation is because it's going to be pulling from the insertion point right here at the pes anserinae and kind of like twisting the thigh laterally, or twisting the leg / thigh laterally, right? And then it flexes the leg at the knee because it's going to be attaching to the tibia and pulls the tibia, thus bringing the tibia backwards, causing flexion of the leg at the knee. So that's just in order to help you understand what these movements are. And then you have femoral nerve. So here's your pectineus muscle. Obviously, he's not going to test you on these images. I just put these images here just to help you visualize where these muscles are. So for example, I look at this and I'm like, okay, pectineus is getting the superior pubic ramus, because I know this is the pubic ramus, right? And it's like the top portion of it. So the superior pubic ramus, it's going to attach roughly around the posterior side of the femur, or like the linea aspera, roughly around there. But its main action is going to be flexing the thigh. No, its main action is going to be, flexing the thigh at the hip, as well as adducting the thigh, right? Because if you pull this muscle, right, it's going to pull the femur towards you, right? It's going to pull the femur towards you, meaning adduction, right? So that's what this pectineus muscle is doing, right? And it's going to flex the thigh at the hip because of the angle of it. Because the pectineus is kind of has a sharp angle like this, right? It's going to actually pull it up a little bit as well. If the pectineus was horizontal, it would solely be an adductor, right? Because it's just going to be bringing the leg back. But because it kind of has this diagonal angle right here, it kind of helps with pulling the femur up. You can see that, right? That's why it flexes the thigh at the hip. And remember, important to note, it takes femoral as well as obturator nerve. I would say that's important. And here's your sartorius, right? So you see how these cartoon images, I guess, kind of help us when we look at cadaveric images, because this is our sartorius, our little seatbelt muscle coming straight down, going from the ASIS all the way to the pes anserinus. Again, 2-joint muscle, right? Super important. So which structure is this? So this one that is pointing out with the white arrow, little comprehension check question right there. Okay, I'll give you a few more seconds. Okay. So yes, it's going to be your iliacus. This is going to be your iliacus muscle. This right here would be your psoas major, right? So this would be your psoas major, and this would be your iliacus muscle, right? So yes, really good job, y'all. Okay, so he put all these muscles here for the quadriceps femoris. So remember, quadriceps, a quad, 4. So it has 4 muscles, right? So the most superficial one is going to be the rectus femoris, right? Deep to the rectus femoris, so just deep. So if you remove the rectus femoris, you should be able to see the vastus intermedius, which is just deep to that, right? And then you have the vastus lateralis on the lateral side, and the vastus medialis, which would be on the medial side, right? I put a star here because the rectus femoris is a 2-joint muscle. None of the other quadriceps muscles are 2-joint muscles, only the rectus femoris. The reason why is because the rectus femoris attaches to the anterior inferior iliac spine, so the AIIS, right? So that's going to be the rectus femoris, which is part of the hip, right? So it's going to cross the hip joint, and it's going to attach to the common tendon of the tibial tuberosity, right? So it crosses the hip joint as well as the knee joint, which is why the rectus femoris is going to be a 2-joint muscle. Vastus lateralis, vastus intermedius, and vastus medialis are not 2-joint muscles. The reason why is because its proximal attachment for the vastus lateralis, for example, is the greater trochanter of the femur, right? So it's going from the femur, and it's only going to be crossing the knee, right? So it's only 1 joint. Vastus intermedius, proximal shaft of femur, again, just crossing the knee. Vastus medialis, linea aspera, only crossing the knee. So the only one that crosses the hip and the knee is going to be the rectus femoris. And again, rectus femoris, superficial. If you remove the rectus femoris, you should be able to see the vastus intermedius. Think on the lateral side, you have the vastus lateralis, and on the medial side, you have the vastus medialis, right?
So while we're on the topic, Justin, the only two joint muscles in pretty much the whole lower extremities would be the sartorius, the rectus femoris, and gracilis. Is there any I missed?
So all the hamstring muscles are two joint muscles as well.
Oh, okay.
Yeah. So yeah. That's important to note too. Yeah, all the hamstring muscles are two joint muscles as well because they attach to the ischial tuberosity, which is like part of like your hip, right? And it's going to cross your hip joint, and it's also going to cross your knee joint.
Okay.
Yep.
Thanks.
Yeah.
Man.
So yeah, I would put that. I should have made like a little category for that, but yeah, I would put all your two joint muscles in one category as well.
Cool.
But yeah,
could you repeat that? About
the
hamstring muscles. Sorry.
Yeah, no, I got you. So for the hamstring muscles, which are like all of them, obviously except for the short head of the biceps the biceps femoris, because that's only going to go to the linea aspera, so it's not going to go all the way to the ischial tuberosity. But all the other hamstring muscles, like the semimembranosus, the semitendinosus, and then the long head of the biceps femoris, are all going to go to the ischial tuberosity, which is right here. This is your ischial tuberosity right there. Right, and it's going to then go back and it's going to cross your knee joint, right, and it's going to attach to your tibia. Right. Does that
so
help?
You have 6 two joint muscles. Is that correct? The gracilis, the semitendinosus, semimembranosus, biceps femoris, long head, rectus femoris, and gracilis.
And gracilis, yeah. Yeah, that's all of them I can think of right now. If I think of any others, or if you all think of anyone else, let me know. But I think that's all of them for the lower extremity right now. Yep. Okay. So here we are. So again, like I just broke down each of these muscles really quickly into super simple slides. So here's your rectus femoris going from your AIIS, basically anterior inferior iliac spine. So you can see none of your quadriceps muscles are going this high up, right? It's only your rectus femoris. Then it's going to your tibial tuberosity, so it's crossing the knee joint, and then it's going to help with flexion at the thigh, which makes sense, right? Because when you pull your rectus femoris up, it's going to pull your femur up, right? It's going to pull it up. It also extends the leg at the knee, right? The reason why it does that is because it attaches to the tibial tuberosity, the front side. So if it pulls, it's going to pull your leg up, basically. When I say leg, remember that's going to be the portion that's below the knee, right? So from the knee to the foot. So that's going to be that. But again, remember, flexed thigh at the hip, that's going to be rectus femoris. Your other quadricep muscles don't flex your thigh at the hip, right? Because they can't do that because they don't go all the way to the hip, right? So this is going to be a two joint muscle, and it's going to be femoral nerve. So you can see here, like in the vastus lateralis, I only put extends the leg at the knee, right? It only extends the leg to the knee because look, this vastus lateralis doesn't go all the way to your hip. Since it doesn't go all the way to your hip, its only action is going to be extending the leg at the knee because it's attaching to the tibial tuberosity, right? Over here. And it's going to be basically like flexing the leg at the knee. So basically bringing your leg up. And it's going to be femoral nerve. Femoral nerve for that. It's femoral nerve for almost all of these. Yeah. And then you have vastus intermedius muscle, which is like right here in this image. If you remove the rectus femoris, you see the vastus intermedius, which is right here. Right. This would be its attachment. Basically just proximal shaft of the humerus, right? But it doesn't go all the way up to the hip, right? And then it's going to attach, obviously, to the common tendon of the tibial tuberosity, and it's going to extend the leg at the knee. Remember, that's its only action, extend the leg at the knee. And then note, it's going to be deep to the rectus femoris muscle. Again, if you remove the rectus femoris, you should be able to see the vastus intermedius. And then you have femoral nerve, which is going to be obviously supplying all the quadriceps. But I put it on all the slides just to remind you. And then vastus medialis, it's going to be on the medial side, right? It's going to be over here, attaching more so to like the lesser trochanter, but it does not go all the way to the hip, and it's going to attach to the common tendon of the tibial tuberosity. So it's only going to extend the leg at the knee, right? And it's going to be femoral nerve, which is why I put like all these images in here. So again, like now we have like a good picture of like what these muscles look like in like obviously animation or cartoon images. This would be, excuse me, this would be the rectus femoris right here. And you could tell because you could see it crossing the hip joint, right? So since it's crossing the hip joint, I'm like, I know that this is going to be the rectus femoris. right? Because if we know we're looking at the anterior portion, this would have to be the rectus femoris, which is going all the way and crossing the hip joint. So it would be a 2-joint muscle. That's going to be the rectus femoris. All right. What did he know here? Oh. Sorry. Gonna clear my throat. Okay, so you have here he didn't say anything. He just said that quadriceps tendon, patellar ligament, etc. They're all like used like interchangeably because some people call it ligaments, some people call it tendons. Not that high yield. Just know that they're just gonna attach to the quadriceps tendon / like patellar ligament. Okay, so here's going to be the arterial supply. We talked about this already, like in the last or throughout these lectures. So again, I just put like a little summary slide because I feel like it's easier to see it like in bullet points rather than like in a paragraph. So I put like anterior thigh, remember femoral nerve and femoral artery. Remember medial thigh, obturator nerve and obturator artery, posterior thigh, perforating branches of deep femoral artery, as well as the sciatic nerve. Right, that's basically everything that he's talking about here. Another thing important to know, remember, obturator artery comes off the internal iliac artery. Right? Again, obturator artery is going to be coming off the internal iliac. Okay, so here's our cadaveric images. So this is going to be your external iliac right here. This is going to be your external iliac artery. This is going to be your internal iliac artery right here. Right? So external, internal. Everybody see that? So internal iliac, external iliac. Right, so external iliac is then going to go and turn into femoral artery, right? So if you keep going down here, it's going to turn into femoral artery, right? So now we're like past this inguinal ligament, right, which is located right here. We're past it, so now this is more so the femoral artery, right? Femoral artery is going to give off the superficial circumflex iliac, which is right here, superficial circumflex iliac artery, as well as the external pudendal artery, which is right here. External pudendal artery. So I put like a note here because I think it's important to note that those are going to come off of the femoral artery, right? So right here. Here's your superficial circumflex iliac, located right here. And here's going to be your external pudendal artery. Right, so your external, remember, external pudendal artery comes off your femoral, no, yes, it's going to come off of your, yes, femoral artery, yes. So you have your superficial circumflex iliac artery, as well as your external pudendal artery are all going to come off of your femoral artery, right? So this is still your femoral artery. Over here, though, this little thing right here is your deep femoral artery, which is a branch off your femoral artery, right? So you know that this is going to be going to the posterior side of your leg, right? Because it's going to be supplying, remember, the perforating branches of the deep femoral artery get your entire posterior side of your thigh, right? This is the deep femoral artery. And then you can see this is going to be your lateral circumflex femoral and your medial circumflex femoral. These are going to be coming off your deep femoral artery. So this is why I put like two little notes here in order for you to separate those, in order to remember which one comes off deep femoral, which would be your lateral and medial circumflex femoral artery, and which one comes off your femoral artery, which would be your superficial circumflex and external pudendal artery. So I wrote that here, and then I hope I cleared up anything that was lost in regards to like which structures are which here. Again, this is your lateral circumflex femoral, and this will be your medial circumflex femoral, coming off your deep femoral artery, right? Coming off your deep femoral artery. They cut off everything else, right? Yeah, question?
Can you go back one slide? I just needed the last line of that last box.
Yeah, you can. What did I say were the anterior? Oh, you know, you can. Can you point out the femoral artery? Yeah, so the femoral artery, this is the inguinal ligament. This is the femoral artery. This thing. This entire thing right here would be femoral artery. And then what did you say were the takeaways from the thigh anterior slide? Oh, so just knowing that the femoral nerve and femoral artery are going to be supplying the anterior thigh. Right? Okay, went over this. And then lumbosacral plexus, again, okay, I point out the deep femoral again. Yeah, so deep femoral is going to be right here. This little branch coming off the femoral artery. This is deep femoral. Deep femoral. Yep, gotcha. Okay, and then lumbosacral plexus, again, I put this here. I'm not going to talk about it again, but again, it's for your study sheets, just to help you organize. Instead, if you want to look at this, you can look at this. But if you want to look at this, you can use this one, which is why I put this image as well. All right, and then remember, inferior cluneal nerve comes off the posterior femoral cutaneous, superior middle come off the dorsal primary rami. Can I point out the external iliac artery? Yeah, for sure. Okay, so external iliac. So this is going to be your external iliac. Technically, it doesn't change like to femoral artery until it passes the inguinal ligament, which would be right here. So right when it passes like the inguinal ligament, roughly, like it's like roughly that area, it's going to be the femoral artery. So this will be femoral artery. So this is external iliac, then turning into femoral artery, which is right here, femoral artery. Right. Same thing over here. This is femoral artery. This is femoral artery. And then this as well will be femoral artery, giving off deep femoral artery. Yep. And then, yep, that's it. Okay, so we have the medial portion of the thigh. You're going to have obturator, right? We talked about obturator. Remember, that's going to be important for muscular as well as sensory, right? So muscular and sensory. So it's going to do sensory portion on the medial side of the thigh, as well as muscular, which would be almost all the adductors on the medial side of the thigh, right? So for this one, he points out what's going to be supplying what, but we've been talking about this like throughout the entire lecture, as well as the lecture before that. Now remember, femoral nerve is going to supply the iliacus, the quadriceps, the pectineus, and the sartorius, right? So you can see that he said iliacus. He does not say like psoas major because the psoas major is not technically supplied by the femoral nerve. But iliacus for sure is going to be supplied by femoral nerve. Quadriceps, which we talked about in the first the first 4 slides when we broke them down. Pectineus, remember that's the odd one out. That's the one that has the femoral nerve as well as the obturator nerve, right? So pectineus has two nerve supplies, femoral and obturator. And then we have sartorius. Sartorius is also going to be femoral, which makes sense because it's on your anterior thigh, right? So that's going to be femoral. So let's see. What else should I point out here? Okay, so this is going to be, so for example, like, yeah, he pointed out basically, like this is your femoral nerve where the, like this white arrow is pointing to. That's your femoral nerve. This white arrow over here is pointing to your obturator nerve, right? So this would be your obturator nerve. Remember, what muscle is in between the femoral nerve, which would be located right here, and then the obturator nerve? Anybody remember what muscle is here or should be here?
Psoas? Psoas?
Yeah, so, yeah, the psoas major. And does anybody remember the nerve that goes just superior to the psoas major? Kind of like runs like right on top of it.
Is it deep femoral?
It's actually genital femoral. So yeah, so genital femoral nerve is going to go right. It's kind of like just going right over the psoas major. So if we saw it here, it would just be going like right over. And then we have obturator. That's going to supply obturator externus. Great, it has it in of its name. Adductor brevis, adductor longus, and the anterior part of the adductor magnus. Right, so it makes sense because obturator is going to get all of the adductors, right? So adductors, bringing the leg and thigh back to the hip, right? That's going to be your obturator nerve. And then you have, it's also important, I put a little star here because the anterior part of your adductor magnus is going to be getting your obturator nerve. The posterior part of your adductor magnus gets your sciatic nerve. I'll talk about that a little bit more when we get throughout the lecture, just to make it make a little bit more sense because they do different actions, which is why they're innervated by different nerves. So I'll talk about that. But remember, anterior adductor magnus is going to be obturator nerve.
Justin, on that picture real quick. So he would call that the femoral, even though it's kind of the external iliac because it's not breaking the iliac spine.
Yeah, so it's, I mean, yeah, he can call, he's not going to say, is it femoral nerve or external iliac? Like if one of them are answer choices, it's going to be one or the other. You know what I'm saying?
All right, thanks, man.
Yeah, I got you. Okay, and I put a little note here again for you to remember. Lateral to psoas major will be femoral nerve. Medial to psoas major will be obturator nerve. And superior, I should have added that, but superior to psoas major will be genital femoral nerve. Okay. Oh, yeah, nothing important here. We talked about this. Obturator artery, obturator nerve. They're going to go through the obturator foramen. Right? So don't let him trick you like on an exam and be like, which one of these go through the for example, like the greater sciatic foramen. Remember, the obturator nerve does not go through the greater or lesser sciatic foramen. It goes through its own foramen called the obturator foramen. So it gets like its little own spotlight type of thing. Okay. So hold on a second. So he gave the muscles here, which are going to be pectineus, adductor longus, and gracilis. So I put a star here again. Gracilis, that's going to be a 2-joint muscle. Again, because it's going from your inferior pubic ramus, which is right here, inferior pubic ramus, which is located on your hip, and it's going to cross so it's crossing your hip as well as your knee joint in order to get to the proximal shaft of your tibia at your pes anserinus, right? So that's going to be important. We'll talk about the pectineus and adductor longus. So again, look, he puts obturator and femoral here again, so I think it's important. I mean, he put it again just for you to realize that the obturator as well as the femoral nerve supply the pectineus. It's like an odd one out. So I would note this too. This is important. So you have, again, pectineus muscle here. We're just simplifying it just into like simple images. You see pectineus, it's like attaching to the superior portion of the pubic ramus, right here, attaching roughly to the linea aspera. It's going to flex the thigh at the hip, right, because of its angle, and it's going to adduct the thigh from the hip. It's going to get femoral and obturator nerve. So femoral and obturator nerve. So I would note that. Adductor longus. So this would be your adductor longus right here. This right here. It's going to be going roughly from some portion of your pubic ramus, right, like the body of your pubis or something like that, and it's going to be going to like roughly to the linea aspera, roughly on the posterior side. Your adductor longus, in and of its name, is going to help with adduction, right? So adduction, and it's going to get obturator nerve, right? Does anybody remember why or what portion of the femoral triangle this is a part of? Like, is it like the medial, the lateral, or like the superior border? Yeah. Medial. Yes. Yep. So the adductor longus is going to be the medial, right? The medial portion of the femoral triangle, right? So that's important to note here as well. And then we have gracilis, which would be right here. So you can see, look at your gracilis attaching from your inferior pubic ramus, because remember, this is like your pubic ramus, so it's the inferior portion. Inferior pubic ramus, all the way to your pes anserinus, which would be like something that attaches to your tibia. Also important to note, this is like kind of foreshadowing that the pes anserinus basically is going to attach the gracilis, the sartorius, as well as the semitendinosus. And yes, they're going to attach to the medial side. So it's important to note that the pes anserinus is on the medial side of your leg and thigh, right? And so the medial side of your tibia. They're all going to attach on the medial side. So it's going to help with adduction, thigh at the hip, right? So it's going to help with adduction, and it's also going to flex and medially rotate the leg at the knee, right? So it's going to flex and medially rotate. The reason why it medially rotates is because it attaches on the medial side. It kind of allows you to medially rotate your leg, so turn your basically leg inwards. 2-joint muscle, high yield, super important, 2-joint muscle, and it's going to get obturator nerve. Then you have your adductors of the thigh. So here's your adductor brevis, which is located right here. This is your adductor brevis. And here's your adductor longus, right? This is your adductor longus. This little arrow is actually pointing to your adductor magnus, which we'll talk about. It's a really large muscle in your adductor compartment. But remember, this is going to be your adductor brevis. This is your adductor longus. And this would be your pectineus, right? So pectineus right here. And here's your gracilis, right? Gracilis is pretty easy to point out. It's like a really long muscle on the medial side, right? So this would be your gracilis. Okay, so which artery would this be? So testing you a little bit here. So is it going to be the superficial circumflex iliac artery, the deep femoral artery, the external pudendal artery, or the lateral circumflex femoral artery? Okay. I'll give you one more second. All right. So yes, it's going to be your deep femoral artery. Yes, really good job. This is going to be your deep femoral artery, and this would be your femoral artery. All right, so really good job on that one. Okay, and then he breaks these down basically into their own components. You have obturator externus, adductor brevis, and then adductor magnus, right? I would also note here, remember, adductor magnus gets obturator as well as sciatic. Remember, the anterior portion of adductor magnus gets obturator. The posterior portion of adductor magnus gets sciatic nerve. So that would be important to know. And then I broke these muscles into their own compartments in the next coming slides, just to make it a little bit easier. Okay, after all this is done. Okay, so here's your obturator externus, right? It's going from just the outside of the obturator membrane, right? And it's attaching on the posterior side right here. So it's going to help with lateral rotation of the thigh at the hip, right? So lateral rotation, because when it pulls, it's going to turn basically your foot outwards, basically, or your leg and thigh outwards. And it's going to get obturator nerve, right? So check, we got obturator externus, that's good, right? We got this based on this slide. Adductor brevis muscle. Remember, adductor brevis is going to be located right here. This is your adductor brevis. It's going to help with adduction of the thigh at the hip. It's going to get obturator nerve as well. And note, it's going to be deep to the pectineus and the adductor longus. So I would note that the adductor brevis is deep to the pectineus as well as the adductor longus. So right, this is going to be your pectineus. Here's your adductor brevis, right? You can't see it too much because it's deep to your pectineus as well as your adductor longus. This would be your gracilis, and this would be a little portion of your adductor magnus, but it's covering most of it, which we'll show. Okay, and then here's your adductor magnus, right? This right here is your adductor magnus. It's going to be attaching to your inferior pubic ramus, like, or in your ischial tuberosity. It attaches to a lot of parts right here, but it's then going to attach to your linea aspera as well as your adductor tubercle. So it's important to note that the adductor magnus technically has like two parts to it, right? The adduction part and the part that extends the thigh at the hip, right? So this portion right here, this portion right here is the adduction part, which helps just bring the leg back, right? That's going to be the adductor part, that's anterior, and that's going to flex and adduct the thigh at the hip, right? So flex and adduct the thigh at the hip. The hamstring part, which is also known as like the posterior part, is going to extend the thigh at the hip, which is this part right here. But it goes like straight up, basically, on the posterior side. So you can think, if you pull that muscle, basically, if you pull this portion of the adductor magnus, right? If you pull it, it's going to basically pull this femur basically backwards, and it's going to extend the thigh at the hip, basically. So the pulling the femur backwards is causing the extension of the thigh at the hip, right? So you see how it has like two different parts to it, because this part right here, which attaches to the linea aspera, is just focused on bringing the femur back to midline. While this part right here, which is more so associated with the adductor tubercle, is going to be pulling the femur back in a way that it's extending the thigh, basically. So pulling this femur backwards, basically. So the anterior portion is going to be obturator nerve, which is this part. The posterior portion is going to be sciatic nerve, which is like this part. Which is why they put like adductor magnus right here, the adductor head, adductor magnus, the vertical or hamstring head, which is right here, because it's kind of like extending the thigh at the hip, which is this portion. So I hope that makes it a little bit more clear as to what the adductor magnus does.
I'm confused, man. So
yeah, it's a little confusing.
The adductor tubercle portion is actually the extending.
Yeah.
Oh, man. Okay.
Yeah, because if you think about it, think about it. So if this muscle is going from your inferior pubic ramus right here and going straight down to like your femur, right? So if you kind of pull that portion back, it's just basically going to pull your femur backwards. Right? Can you see that like visually?
Yeah.
So that's going to be the portion that does that. This portion, which attaches to the side of your femur, is just focused on like pulling the femur back into the midline. So adducting. Do you see that? Does that help?
Yeah, it's just the name throws me, like the adductor tubercle, the femur attachment. You would think that helps with the adducting.
yeah, I know.
With me, man. But yeah, it makes sense. Thank you.
Okay, gotcha. Okay, that's why I dedicated like a slide to this, because I felt like that was a little confusing. So here it is again, going from the ischiopubic ramus and then going to the linea aspera, which would be mostly the portion that's associated with adduction, and the adductor tubercle, which is mostly associated with extension of the femur at the hip. So basically bringing the femur back. perforating arteries basically pass through these little gaps. So like the deep femoral artery sends like a little like branches that go through those gaps, right? But does anybody remember what actually goes through the adductor hiatus? Which is located right here. Like what major supply? What major?
It's your femoral artery to become the popliteal.
Yep, your femoral artery, which becomes your popliteal. Yes. Okay, and then here's your membranous support. Here's your pes anserinus. Again, we've talked about it. I've given you like a lot of foreshadowing in the beginning, so this should be like kind of like a review. The pes anserinus has the sartorius, the gracilis, and the semitendinosus, which is all right here. So the anterior part would be the sartorius, the medial part would be the gracilis, and then the posterior part would be the semitendinosus. Right, so that's important to remember, the pes anserinus. Right, so I put a huge star there. This is not too important. You don't need to like, I mean, you could label if you want, but he's not going to put a CT scan or anything like that. Okay, so the most important thing here is that remember he talked about in class that like these ligaments are like as you extend your thigh or basically like bring your femur backwards, right? These tendons twist and tighten up, right? So they push the femur into the acetabulum, so it keeps it tight. It's like when you said, like if you're sitting in a car and if you put your legs on the dashboard in the passenger seat, which obviously you should never do that, but if you do that, basically your legs are flexed, basically, or your thigh is flexed. So if you get into a car crash, it's basically not only is it one going to crush you, two, your ligaments are not tense anymore. So since they're not tense because your thigh is flexed, you're going to pop out your femur out of your hip very easily. So that's what he's talking about when he's in regards to like the iliofemoral ligament, the ischiofemoral ligament, as well as the pubofemoral ligament, which would be on the anterior side. Okay. That's the pubofemoral ligament, right, which is the anterior side. Okay, nothing else too important here. Okay, just a list of things. I mean, he talked about this a little bit. I mean, just know, like, I mean, things attached to the ligament. You have a ligament at the head of your femur, the neck. That's nothing too important here. You have lateral femoral cutaneous and medial femoral cutaneous. Remember, we talked about this earlier. These are going to be coming off the deep femoral artery, right? And they supply the neck of the femur. So lateral femoral cutaneous and medial femoral cutaneous come off the deep femoral artery. And this is going to be the femoral artery. Right? Yep, lateral. This is going to be lateral, and this is going to be medial. Again, here we are again. He put a lot of slides on this, so I feel like this is important. Then the deep femoral artery gives off the lateral femoral cutaneous and the medial femoral cutaneous, right? And it supplies the neck of the femur. Remember, he said the head of the femur is actually supplying by like another branch of the arteries. Okay, it's actually like this acetabular branch of the obturator artery. Okay, and then here. I mean, we talked about this already. Femoral nerve, anterior thigh, obturator nerve, mostly medial thigh, and then sciatic nerve is going to be the posterior thigh. Right, sciatic is going to be from L4 to S3, right? L4 to S3. Attachment. I mean, this is just how muscles move, right? I don't think there's anything that's testable on here. Just know, like how I've been saying, like when you pull the muscle, like that's how like it moves basically on where its origin is and where its insertion is. Okay, all those, and then this again. And that's it. So we went a little bit over time, but not too far over time. So I hope those lectures helped. Any questions? I'll be willing to stay here. Please let me know if you need anything, need any assistance regarding anatomy, regarding mental health, anything along those lines, because I know like exams are coming along and it's getting really stressful. So I want to make sure you guys are in the right mind state as well as feeling as prepared as possible. So yeah, let me know.
So real quick, I don't know if you can help me, man, but on Proctorio, I'm just having a lot of issues. Like I have a MacBook Air from 2012, and I can't get like the microphone test that you do for Proctorio. It passes like a third of the time, and then it never passes the screen share. I went into the settings, I did all the troubleshooting they recommended. Like I want to be able to take this practice test today. But I don't know if I should reach out to like someone else from like IT or something, or
yeah, that's it's really, you're using Google Chrome, obviously, right?
Yes. Yep.
That's weird. I would hit up IT with that, because if you're trying all those things, I don't know what else I can tell you with that.
I know for me, I also use a MacBook. Just by going in, when you go into your settings, you can see your input and output of your audio. And if I just move that a tiny bit, then I notice that it'll start picking up my mic.
Yeah, I put the input all the way up on that, and it still is like really hit and miss with the test.
Yeah, I mean, I'm not too tech, like I'm not good with tech, so I would hit up IT.
Like headphones in?
Huh?
Do you try putting like headphones in, like putting headphones into your jack and then like using that mic instead?
Can't do that. Said headphones are a no now.
Yeah, you can't use headphones.
Just kidding.
But yeah, I would hit up IT.
All right, cool. Thanks, man. And thanks for everything today, as always, bro. I appreciate it. We all do.
Of course. Oh, yeah, and then anybody who's going to the 2 p.m., I'll see you there. Yeah, I'll see you at the 2 p.m.
Hey, Justin.
Yeah.
I had a quick question. Could you just go over the pudendal nerve and the genitofemoral nerve?
In regards to, like, where they...
Yeah, just like, what do you think we need to know about them? Because they've kind of all over, so I kind of got a little confused.
Yeah, so for the most important thing for pudendal nerve is that it goes out the greater sciatic foramen and comes back in through the lesser sciatic foramen, right? The reason why it comes back in is because it needs to supply your genital area, right, like your perineal area. And then in regards to the genitofemoral, the most important thing I would note for that is that it is going to be superior to your psoas major. That's your genitofemoral.
Thank you.
Yep.
Can you just describe which one's the apex of the femoral triangle?
Yeah, it's going to be so you know how we said like it's going to be inguinal ligament, then sartorius, and then you have adductor longus. Right, this little bottom corner right here, that's going to be the apex.
Okay, so it's between the sartorius and the adductor longus.
Yes.
Okay, thank you.
Of course.
Hi, Justin.
Hi.
I know that you've went over this like quite a bit of times, but I think I'm still like just kind of confused and worried, I guess, because this is the first exam and we all want to do well. Mm-hmm. But can you kind of like go over the layout of the test and like, I don't know if like you know how he's gonna do the test, like if you get to see before like we take it or anything, but I guess just like how it's going to be, like how much of each lecture it's going to be on, if it's going to like overlap with lectures, kind of stuff like that.
So I think it's pretty evenly distributed amongst what lectures. I don't see the exam, so I have no idea what's going to be in the exam. And then with last year, like I said, we didn't have cadaveric images, so I'm just trying to see like how Muffley tests, because I know how he like kind of asks questions. So I'm trying to ask those questions in regards to cadaveric images, just to see maybe this is how he'll ask it. But other than that, it's mostly just like either one, recall, like straight up recall, like which would be like what's the innovation of this. Two, which would be like secondhand thinking. So for example, like if I point at a cadaver image and I ask you what is the innovation of that, like you have to know what that is and then know the innovation. And then three, like which is going to be like obviously like very like odd questions out. Like when I talk about like with the pectineus, like is going to get femoral and obturator, like those types of questions. Things that are a little bit like outside of the like you need like a little bit of like extra like thought into something in order to answer that question, for example. But I don't see the exam, so I have no idea. But Muffley does. I know he tests hard because obviously I took the class last year, so I want you guys to be prepared as possible. And I'm trying to like make sure that I'm testing those cadaveric images in regards to the way that he would most likely test them as well. But yeah. So.
Do people usually finish the test on time, or has there been like a lot of people who have to like find that they have to rush at the end?
No, with anatomy, you're usually pretty fast. I would say immuno is the one that people get a little bit rushed because almost every question is like clinical vignettes. So like you have to read like 3 sentences before you get to the question sometimes. But anatomy, you're mostly gonna finish pretty early, I would say.
Justin, I had a quick question regarding the questions for attachments. Since you covered like so many muscles, like 1 through 8 already, like lectures 1 through 8. is there going to be like direct questions that are like, this is the lateral attachment? Because there's so many for each muscle. So I'm like trying to remember everything and then have cadaver pictures that are just zoomed in. I get confused. I'm like, oh, okay, that was a lateral, that was the inferior attachment or something like that. So
yeah, so I don't know how high yield it is. That's why I said like when a muscle, like when you talk about the gluteus maximus, like it has like 4 proximal attachments. Like he's not gonna. I highly doubt he's gonna be like, is it sacral tuberous versus sacrospinous ligament that it's proximal attachment? You know, it's not really that relevant, right? He's more so to ask questions that are like pretty relevant. You know what I mean? Like, so he'll ask tricky questions, but he won't ask like petty questions like that. Like I feel like that's petty. Like, you know what I mean? That's just like asking the difference between what's closer to what, you know what I mean?
Exactly, yeah.
So,
and then how about function? Because I know a lot of the muscles, they have their listed function and then some of them don't. Should we know their like basic function for some of them?
So I would know the basic function, the main functions at least for most of the muscles. And then some of the minor functions that he talks about, I would note those as well. But I would say in general, if you know the origin and attachment, you should know like exactly what the muscle does. And and in regards to origins and attachments, like I said, remember like coracoid process, like that's obviously super important, right? That's not something to ignore. Like you want to know what muscles attached to that, right? But with the gluteus maximus, it's like 4 attachments. I wouldn't go and like recommend memorizing all 4 and making sure you have them, you know, like down packed. You sometimes like some of them are super important, while others are like kind of like you can brush over it just a little bit. You just have to know like kind of the general area.
So for like the biceps brachii and the coracobrachialis and the brachialis, we should know that that's for, not the brachialis, the just biceps brachii and coracobrachialis, that's a coracoid process?
Yes.
Sorry,
No, okay. You're good. Yeah, the pec minor, the short head of the biceps brachii, and then the coracobrachialis are all going to attach to the coracoid process. Like those things, that's important. Like those attachments. Yeah.
And then the the brachialis and the triceps brachii are the coronoid process, or?
So it's the actually the brachialis and the pronator teres that are the coronoid process of the ulna. So remember, that's like coronoid process of the ulna. It's not on the radius.
Okay. Thank you so much.
Yeah, I got you for sure.
Justin, I had a question. You know how he does the coronal images, and he's like, you should be able to identify these muscles. Do you have any hints or tips to be able to identify right from left? Because I notice at times, like, I'm right-handed, and so I naturally gravitate to studying, like, the right-sided, like, from the muscles, like, studying them in order from the right side. So then, like, I think it was on this deck, if you go up a couple of slides, where he was showing the coronal image, it was, like, basically a left-sided cut. And I was like, oh, crap. So do you have any hints on being able to get yourself like from right to left? You're trying to identify your muscles? Yeah. So usually like when if there's an image and you see the midline, like when I mean midline, for example, like the spine or like the sacrum or like anything associated with the pelvis, you know that anything like away from that midline is going to be left or right, right? So usually I like try to find things that are going to be associated with the midline. And most of the time in regards to images, like the cadaveric images, I don't think he's going to ask you, is this the right like quadricep, like rectus femoris, or the left rectus femoris? I mean, if he does, then you can tell, for example, based on seeing that that's going to be the hip basically, or the os coxae. If you see that the image is on the right hand side, for example, or like if you picture yourself being that sacrum basically, then you would know that that would be basically the right leg, right, or the right thigh, for example. So, for example, like I guess like picturing yourself in the image kind of helps me remember like which one's going to be right and which one's going to be left. Okay, thank you. Yeah, of course.
Hey, Justin. Can you point out where the psoas major and the iliacus becomes the iliopsoas? I'm just having difficulty.
Yeah.
That.
Yeah, you're good. Hold on, let me get. Let me just share my screen real quick. Let's see if they have a picture of that. Yeah, I mean, so this picture does us a little bit of justice, but this is the iliacus, right? And then this is going to be the psoas major, right? And then eventually they kind of fuse together right here and go to the roughly the lesser trochanter of the femur. Do you see it right here? They're kind of like mixing together.
Yeah, I see that. Okay,
thank
you.
Yeah, I know it's a little hard to see because he doesn't put too many images of it. So I wouldn't. Let's see. Yeah, it's like right here too. Hold on. You see, so. Yeah, so like right here, right? So you have your iliacus, which is on this side. You have your psoas major on this side, and then they eventually, when they go more towards the end or the distal portion, they kind of fuse together right here, these two muscles, and then they make the iliopsoas.
Okay, I see it now. Thank you.
Okay, got you again.
Hey Justin, I have a question.
Yeah.
I tried to rewatch yesterday's lecture, and I don't see it on Panopto on the cloud. Has he uploaded it yet?
I don't think he's uploaded it yet. Yeah, I tried to look for it too, but I don't think he's uploaded it yet. You can check though. Oh no, it hasn't.
Do you think? Do you have an idea of like when he's gonna upload it, or?
I don't have control of like when they post the lectures. You would have to either email Muffley or Rose.
You can rewatch them in Teams if you go back in the chat room. If you go back in the history of the chat on Teams, you can rewatch them there.
Okay.
Oh, that's awesome.
Perfect. Thank you.
Welcome.
All right. Okay. If you guys don't have any questions then, thank you so much. I'll see any of you guys at the 2 p.m. And good luck with your studies. And please feel free to email me if you have any questions. And I'll see you on the next review session, which would be Wednesday. Yeah, just coming Wednesday for the last lecture. All right. Everybody have a good day, okay? Take it easy.